welcome to this public forum on the epidemiological studies concerning the landfill. What you probably don't know is that this is also a special meeting of the Board of Public Works. My name is Dave Rackham, I'm chair of the board. And the board members are mostly here. Mike Parsons in front, Rose Schmidt, Susan DiMaria. We have Jim Dostal, who's also president of the City Council, and Terry Cohen, who's doubling as our tech guy tonight. And did I get everyone? Is Gary here? I don't see him. Okay, so what I would like to do first is open this meeting of the Board of Public Works, and I'd like to entertain a motion from the board to use the video recording as the record of the meeting in lieu of minutes. Is there a motion? Is there a second? All in favor?
Aye.
Opposed? Passes. Good, thank you. This is a meeting with only one item on the agenda, which is the public forum on the landfill, focusing specifically on the epidemiological studies. We're very fortunate to have with us the Massachusetts Department of Public Health, Gradient Corporation, and Dr. Richard Clapp from Boston University. Someone asked that I clarify their roles in this, and so I'll do that now. The Department of Public Health is funded by the Commonwealth of Massachusetts. Gradient Corporation is under contract with the city, and Professor Dick Clapp is doing the scribes, so thank you very much. We will have one more public forum. This is really at least one more on the landfill. This is the second in a series. The first one was several weeks ago, and it concerned the groundwater modeling study, and we had two excellent speakers talking about the study, the groundwater, and both sides of the issue. Today, I think we'll have some agreement, maybe some disagreement among the experts too. This one is extremely important, though, to us. It's concerning epidemiology and cancer. If I could speak on behalf of the board, I know that cancer is a very serious issue for us, and we're certainly not going to act in any way and try to encourage the city to do anything that would increase the risk of cancer to the citizens of the city, or any illness. So we're going to talk about the two studies. We're also going to have a third public forum. I'm not sure exactly when that will be, but sometime in the not too distant future, to look at options. The options for what we would do if we were if we were to close the landfill. And in advance of that meeting, and this meeting will give an opportunity for a couple of the city's consultants to report on these issues. But in advance of that meeting, we'd like to have another meeting to solicit ideas and alternative options from the general public, and so we'll announce that when we've set a date for that one. We hope you will be able to come to that one. The objectives tonight are really threefold. Number one, my own very maybe selfish personal objective is to help inform the Board of Public Works on the issue of cancer and other illnesses as they relate or don't relate to the landfill. The Board of Public Works will have to make a decision on whether to go forward with a special permit, and this is a decision we're going to be making in the coming months, and so it's important that the board be as informed as possible. Another objective is to inform the public on this issue, and we do of course have the experts here to do that, and to help us with that we'll have a question and answer period after the experts have had a chance to speak. And then the third objective is really just to air public feelings and concerns about the issue of epidemiology, cancer, and the landfill. So to help us with this, our only item on tonight's agenda is a guest facilitator. We have here Sarah Cohen, who is working with the Consensus Building Institute for this particular project. Sarah lives in Eastern Massachusetts, and in the interest of full disclosure, she has not had any direct connection or association with the landfill issues. So at this point, if I haven't forgotten anything, I will turn the floor over to Sarah.
Thank you, Dave. And I want to repeat his thanks to all of you for coming today, bringing with you this meeting your intelligence and your concerns and your patience. You'll probably draw on all of those over the course of tonight. We've got a long meeting. As Dave mentioned, I'm working with the Consensus Building Institute in this role, and the Consensus Building Institute is an organization that provides mediation and facilitation services around the country on issues of public concern. That includes issues of the environment, on public health, on public policy. And I'm very happy to have been asked to come help this meeting be productive tonight. My goal is to make sure that the conversation remains productive and that people have an opportunity to get their questions answered to the best of the ability of the experts that we have here tonight, and to track the questions that we're not going to be able to answer tonight. To orient everyone to what's going on, I'll talk a little bit about the agenda, and just to repeat that what Dave mentioned, that there are two purposes to tonight's meeting. One is for the board to become as informed as they can with the up-to-date information on recent studies, looking for any possible link between the landfill and public health, and have an opportunity to ask questions of those researchers. And the second purpose of the meeting is to make sure that at the same time the public is becoming informed with that same information and has the same access to the experts to ask their questions and air their concerns. So I think even if people have patience for a long evening, I think we can achieve all of that. And we're trying to, if you look at the agenda, you'll see that we're trying to pack a lot in and balance, really, the maximum opportunity for exchange among the people here and just some physical needs, to get up, to stretch, to use the bathroom, get home before tomorrow. So I'm going to ask for your help a little bit in keeping things moving along, staying on topic. We're going to hear presentations, again, from the Department of Public Works on a recent, Department of Public Health on a study that they've recently completed, from the Gradient Corporation on a study that they've completed. Actually, after the first full hour of presentations from the Department of Public Health, we're going to take a quick break just to stretch. Then we're going to come back and hear from Gradient Corporation on a more narrow question that they addressed in their study, and hear from Dr. Clapp from Boston University, who's been asked by the community to provide an independent review of the Gradient study. And then we're going to open up the floor for almost a full hour of questions from the public. After that, we're going to take another quick break, and then open up the floor for questions and concerns from the board. I'll be working to make sure that we get through this agenda, and I'm going to ask for your help in a couple of ways. I'm going to ask that people think about their questions to be as concise as they can. Try to keep your time at the mic to no more than a minute or two, and try to refrain from commenting on one another's points and concerns as well. That includes clapping, calling out of turn. And of course, I'm going to ask people to be respectful. I don't expect that to be a problem. And if you do come to the mic, speak from your own experience. If it seems to me that I'm hearing concerns or questions come up that we're not going to be able to address tonight, there's not the expertise here, then I'm going to be trying to track those concerns on the flip chart and direct attention to possibly future opportunities to have some of those concerns addressed. That being said, a couple of quick logistics. I don't know if everyone's found that the bathrooms are down this hall and to the right. After you take your first right, I'm going to ask people to turn your cell phones off, please. If you haven't signed in, there was a sign-up sheet that was going around. Where is that? It's going around. If you haven't gotten it by the first break, you could track it down. It'd be good to have a record of this here. And given that there's a lot of sitting at this meeting, if you need to get up and stretch your legs, please do so. There's a lot of time that's going to go by sort of sitting and taking in information. So if it'll help you stand up, stretch a little bit, try to be as, just disrupt things as little as possible, but do what you need to do to take care of yourselves. So I'm going to turn it over to the first speaker now, first two speakers. We've got Lawrence Romberg and Julie Goodman from the Department of, we've got, from the Department of Public Health, we've got Jan Sullivan. I was introducing the second speakers. So I encourage you to take notes on any questions that you have as they come up. so that you don't forget them. And they may be answered by subsequent speakers, but it'll be good that you don't forget what they are. So take notes on things that come up for you.
Good evening. Can people hear me in the back? Jessica is going to pass out a copy of all of my slides so that if you want to take notes during the presentation, you can do that. So,
Louder would be better.
I'm sorry?
Louder would be better. If we possibly possible.
All right. I'm from the Massachusetts Department of Public Health. Is that better? All right. Try it. My name is Jan Sullivan. I work at the Massachusetts Department of Public Health, and I'm director of the Community Assessment Program. And I want to tonight talk to you about the review that we did of various sets of health statistics and other relevant information. First, I'm going to just give you a little bit of background on our involvement. Then I want to talk and explain the methods that we used to evaluate the health data that we looked at. I want to summarize the key findings of our evaluation, present our conclusions, and then after all of the presenters, there'll be time for discussion. So we were made aware about a year and a half ago of local concerns about various, particularly concerns about cancer incidents in Northampton. And we had been contacted by the director of Northampton's health department back then, and we've also heard from some concerned residents, as well as from the mayor's office, all of them asking us to take a look at the health status of the community. Just a little background, the Community Assessment Program that I direct is the group in the state of Massachusetts that responds to requests for evaluations of possible disease clusters. And we're also asked to investigate possible links between exposure to environmental contaminants and possible adverse effects on health. So I mentioned about a year and a half ago, we were asked by the Northampton Health Director to help respond to local health concerns. We responded a month later or so saying that we'd be glad to do that, but we asked for some more specific information about those concerns. Then in April of last year, Mayor Higgins asked the health department to facilitate Gradient Corporation obtaining cancer incidence data. And that was done through the Massachusetts Cancer Registry. A few months later, some residents wrote to the Federal Health Agency, the Agency for Toxic Substances and Disease Registry, expressing concerns about the landfill. And the bureau that I work in has a cooperative agreement with ATSDR, and so the federal agency asked us to respond to those concerns. Last summer we came out and we met with local officials to hear directly what the concerns were. And then last October we were out here at the Finn School where we presented to the community what our approach would be to do this. So I'm here tonight to report to you the results of that evaluation. So we looked at a number of different, what we call health outcomes. We looked at cancer incidence data. We looked at birth defects data. We also have information on low birth weights, births. We have some school-based asthma data that we evaluated. We also have some hospitalization rate data for asthma and asthma-related conditions. We have access to data on childhood blood lead levels. And then we have some data on autism prevalence in the state. So we basically reviewed all of the available data to us for both Northampton and Easthampton. We also, when we looked at these data, we also looked at the patterns in a geographic sense. What are the spatial patterns of disease in the communities? I want to point out that when we do these kinds of evaluations and we do them across Massachusetts, we really think of them as screening level health assessments. This is not a study that says, it's not meant to establish cause and effect. The way we look at it is we do a careful review and we look for red flags. Is there anything unusual going on that we can't explain or that appears just out of the ordinary? So what did we do in terms of looking at cancer? We calculated cancer incidence rates for Northampton and Easthampton. We also looked at 2 census tracts, one in Northampton where the landfill is located. We also looked at cancer incidence data for the census tract in Easthampton that borders the landfill. We also, we're aware that a lot of the concerns are very local. It's neighbors who live near the landfill. So we also drew a 1-mile radius around the landfill, and we looked at the cancer patterns within that 1-mile radius. I mentioned that we look at geographic or spatial patterns. We also look at temporal patterns. We look at the dates of diagnoses for various types of cancer to see if there's any clustering in time. And then we also review available risk factor information. Risk factor is basically anything that can increase your risk of developing cancer. And what I'd like to stress is that when we do these kinds of investigations, we really rely on all of that information to come to conclusions. We don't base our evaluations just on statistics. We don't base them just on spatial patterns. We really, it's this, what we think is a pretty comprehensive approach to evaluating all of the data. The Massachusetts Cancer Registry is part of the State Health Department. They're the custodian of cancer incidence data for the state. It's a surveillance system that's been in place since 1982. It's established by law. Physicians in the state are required by law to report any new cancer diagnoses to the Massachusetts Cancer Registry. And it's, as you can imagine, a confidential database. So I will not be showing any maps tonight to protect privacy. When we started this evaluation, the most current year for which we had complete cancer incidence data statewide was 2004. So when I report to you cancer rates, I'm reporting for the 23-year period from 1982 to 2004. I also will point out that when we looked within the 1-mile radius, we actually could go from 1982 to the present. So I will talk about that a little bit more. I also want to let you know that the Massachusetts Cancer Registry typically, for the last 5 to 10 years, obtains information on between 95 to 98% of the diagnoses that occur in the state. And that's a very high case ascertainment rate, and the Cancer Registry is thought of as one of the best in the country. So it's a very thorough and high quality database. So I mentioned statistics. The statistic that we calculate when we do these evaluations is called a standardized incidence ratio. And it adjusts for gender differences. We look at rates for males, rates for females, and rates for males and females combined. And it adjusts for age differences in populations. And age is a very important risk factor for all cancers, essentially. So an SIR is the ratio of the number of reported diagnoses to the Cancer Registry, the number of reported or observed diagnoses, and it's divided by the number expected. And the way we obtain the number expected is that we apply statewide cancer rates to the population of the community of interest. And that tells us how many diagnoses of a particular type of cancer we would expect if the community experienced that cancer in a way similar to the state as a whole. So if the SIR equals 100, it means the experience of the community is similar, about the same as the state. If it's above 100, it means the community's experienced a higher incidence of cancer. And similarly, if it's lower, it's a lower than expected incidence. We also do a statistical test on each SIR, and we do this because there's always some variability in cancer rates across the state and within communities. It's very natural for that to happen. And so one way we want to get a handle on that is by calculating what we call a 95% confidence interval. And this allows us to test whether that variability is just probably due to chance or natural variation, or whether it's not. And this confidence interval, when it's very wide, it reflects relatively small numbers. That means that the SIR is somewhat unstable, and that an additional diagnosis or two can change that SIR greatly. When we look at statewide SIRs, you'll see that the confidence interval is actually quite narrow, and that's because it's a more stable number, because we're looking at all diagnoses in Massachusetts. I also want to point out, when there are fewer than 5 diagnoses for a particular cancer type, we don't calculate an SIR because of the small numbers, but we do calculate an expected number, so we do have something to compare to. So when we were asked to do this for the communities, we reviewed the environmental sampling data that have been generated associated with the landfill, and we identified chemicals that have been detected. And we chose cancer types for which there's some association between the particular type of cancer and a chemical exposure. There are a number of cancer types. An example would be melanoma, where there is no evidence that exposure to a chemical will increase your risk of melanoma. So these are cancer types where the weight of the evidence is greater, that there could be some link with an environmental exposure. Now, the first 8 cancer types are those where there is this environmental association. The last cancer type, Hodgkin lymphoma, is one that we know was of particular concern to some residents. What I wanted to point out with that is that the consensus is that Hodgkin's is associated probably of viral origin. There's a couple of viruses that have been linked with increasing a risk of Hodgkin's, and it's one of the well-studied types of cancer. So we selected that because of community concern. The others we looked at because of stronger evidence of an environmental link. So for this evaluation, again, we looked at 23 years worth of cancer registry data, and we looked at it in 4 smaller time periods. And that allowed us to look at trends with respect to the state experience. So we had 3 5-year time periods that we looked at, 82 to 86, 87 to 91, and 92 to 96. And then we looked at an 8-year time period towards the end there. And we chose these time periods to be consistent with gradient. I want to point out that, I should point out, for the last time period, you are going to see a jump in the number of reported diagnoses, the number of observed, as well as the number of expected, simply because we are looking at 8 years worth of data. The other thing that you should know is that beginning in 1992, the Massachusetts Cancer Registry started collecting what are called in situ, or non-invasive cancers. That was not true earlier on, and I will talk about those type of cancers as I get into the details tonight. So we looked at all of Northampton of these health statistics. Then we also, knowing that the concerns, a lot of them are local, we then looked at the census tract where the landfill is located, and that is, this is the landfill right here. So the census tract in Northampton is 8222. And then we looked at the Easthampton census tract that borders the landfill. And then I will show you after the 1 mile radius area that we looked at as well. I mentioned that we looked at risk factor information. The reason we do that is that we do see a lot of variability in these rates across the state, and we try to drill down and look as closely as we can so we can understand if there is anything unusual going on. The Massachusetts Cancer Registry, in addition to learning of a new diagnosis, for each individual, these 5 factors are collected. There's information available on them. I want to point out that the occupational information is somewhat limited. It's not a full occupational history for anyone. It's what they report when they're diagnosed as their usual occupation. A lot of times we see that someone reports they're retired or their occupation was unknown. But we still look at it to see if there's anything we can glean from it. We have age at diagnosis. Of course, we have gender information. There is smoking history reported at the time of diagnosis. And then we know the residence at diagnosis. And so all of this information we look at if there's an elevation in a particular cancer type. When I say an elevation, we take a very protective approach when we do these evaluations. We first look through all of the data, and if there's a difference of 1 or 2 diagnoses, we consider that to be about as expected. If there's more than that, then we will take a closer look. And I'm going to focus tonight on what I think are the main findings. There are a couple of cancer types that I will do fairly briefly because in the interest of time. All of this information is in great detail in the report, and after the meeting or during the questions, I'd be glad to cover things that I've maybe mentioned that you're not getting enough information on. So what I want to point out is the reason that we look at this risk factor information is that in the medical and epidemiological literature, there's information on what are the age patterns? When are people typically diagnosed with a type of cancer? What is the reasonable age range for that? So what we do is when there is an elevation, we compare what we're seeing in the community to what we'd expect based on either the medical literature or on statewide statistics. So that's just another way for us to try to understand what's behind these SIRs. We do not have information on other risk factors that can be very important for certain types of cancer. We have no information on family history or genetics. We don't have lifestyle information that can be important for particular cancers, such as alcohol consumption, diet factors, that sort of thing. So I mentioned we look at maps. We have geographic information software back at the office that's very powerful, that we rely on heavily. What it allows us to do is to plot on a map the residents at diagnosis for every individual that we're evaluating. And we can zoom in with this software to look at neighborhoods. We can look at the characteristics of those individuals who lived in the neighborhood who were diagnosed with cancer. So it's a very powerful tool. For this particular investigation, I mentioned we look at these maps community-wide. We look at them within the census tract. We look at them down into small neighborhoods. And it allows us to, in addition to doing this visual inspection, we also can overlay population density maps onto here. So we can see if there is a group of people, are they living in a densely populated neighborhood? We can also, if it looks like there are a couple of individuals at a given address, we can see if it's a nursing home, for example. So we drill down and we look very closely at all of this data. So I want to start talking about the results. The point that I want to make, and I am going to spend a lot of time going over some of the details here, is that when we looked at these 9 types of cancer, most of the cancer types over the 23-year period that we looked at, in the 2 census tracts as well as community-wide, occurred about as expected, which is very good news. There were exceptions, and I want to focus on those exceptions tonight. So looking at the city of Northampton as a whole, there were 5 of the 9 cancer types that occurred about as expected in every situation, in the census tract, in the city as a whole, during every time period. And these included brain and central nervous system, lung and bronchus cancer, Hodgkin's lymphoma, leukemia, and liver cancer. There were 3 cancer types that I'll talk about in a minute that showed more variability in the rates. And these are the ones that we took a very close look at. And they included breast cancer, kidney cancer, and bladder cancer. Non-Hodgkin's lymphoma was elevated in the first time period in Northampton. It was not what we call statistically significantly elevated, but it was elevated only in that first time period. It's not an elevation that persisted over time. I'm not going to spend time initially talking about that, but as I said, we can talk about it more later. What I want to focus on right now are these other 3 cancer types. So the incidence of kidney cancer in Northampton males was about as expected during the 4 time periods we looked at, so I'm not going to focus on that. You can see with this table that the last time period, 1997 to 2004, there were 23 females in Northampton diagnosed with kidney cancer when we would have expected about 13. And that is a statistically significant elevation. So what do we know about kidney cancer in general? We know that the risk is higher in men than women. We know that the average age at diagnosis is 65. It's uncommon to be diagnosed with kidney cancer under the age of 45, except for Wilms tumor, which is a subtype of kidney cancer, which is the most common type of kidney cancer in children. We know that smoking is a risk factor for a subtype of kidney cancer called renal cell carcinoma, which is the most common subtype in adults. We also know that exposure to some environmental contaminants has been shown to present an increased risk. Contaminants such as cadmium, as well as solvents like TCE and benzene. And most of the information comes from occupational studies where people work with these chemicals for a long period of time, often at very high concentrations. Obesity and high blood pressure are risk factors for kidney cancer, as well as genetic and hereditary factors. And there are certain pre-existing conditions that can put an individual at increased risk. So we looked at the 23 females in Northampton that were diagnosed during this time period. We found that the average age at diagnosis in Northampton females was 64, compared to what the literature tells us is the average age of 65. We looked at the subtypes of kidney cancer. We learned that in Northampton, 76% of the females were diagnosed with renal cell carcinoma, when we would expect 80 to 90% to be renal cell carcinoma. So those 2 patterns were pretty consistent with what we would expect. I mentioned that smoking increases a person's risk of developing cancer, kidney cancer. We had smoking history information for 16 of the 21 adults, and we know that 10 of them reported being current or former smokers at the time of their diagnosis. When we looked at the map of where these 23 females lived, we did not see any unusual patterns. The pattern closely followed the population density map for Northampton. We saw no grouping or unusual distribution or clustering around the landfill. We also looked at, on a map, what did the spatial distribution look like of those women who never smoked, to see if we were missing something by looking at the entire group of women. And we did not see any unusual patterns among the non-smokers. We did review occupational information, and for 5 of the 21 women that reported occupational information, it's possible they could have been at increased risk through their jobs. But again, what I want to point out with that information is that we have no information about job duties or length of employment in the industry, so it's very limited information. I also want to point out that we did look at the Massachusetts Cancer Registry for the years 2005 forward to see what the incidence, how many individuals were diagnosed in these more current years. And based on a crude estimate of an expected number, and that's all we can do right now because the statewide database is not complete, but based on a crude estimate, it looks like the incidence in these last few years is back to about what you'd expect for both men and women. Okay, here are the data on breast cancer incidence. The first time period, you can see there was an elevation in breast cancer in Northampton women. 112 diagnoses compared to about 94 expected. It wasn't statistically significantly elevated, but nonetheless it was elevated. The next 2 time periods, it's closer to what you'd expect. And then that last time period, there's a statistically significant elevation. So we took a close look at both that earliest time period and then the most current time period. So what do we know about breast cancer risk factors in general? We know that 2 out of 3 women diagnosed with invasive breast cancer are diagnosed at age 55 or older. We also know that 5 to 10% of breast cancer diagnoses are thought to be hereditary. We know that if you have a first-degree relative, a mother, a sister, a grandmother who's had breast cancer, that puts you at slightly increased risk. We also know that if a child or a young woman as an adolescent has had radiation therapy to the chest for a previous cancer diagnosis, such as Hodgkin lymphoma, that can put you at increased risk for breast cancer later in life. We know that certain reproductive factors increase your risk, one of them being maternal age at first birth. We also know that early menstruation and late menopause are risk factors, and we know that lifestyle can come into play. A higher socioeconomic status seems to be associated with an increased risk of breast cancer, as well as alcohol consumption and obesity. And there are some possible environmental risk factors as well. There's been a lot of interest in the last several years on a link between estrogen, compounds that have estrogen-like properties, and breast cancer. And it's of great public concern. At this point in time, I don't believe there's an established link, but I certainly think that the jury is still out on that. So what did we see among the Northampton women diagnosed? During that first time period, the 82 to 86, the average age of Northampton women diagnosed was 67, compared to 64 statewide during that time period. And then in the most current time period, the average age at diagnosis was 61 in Northampton compared to 61 statewide. We did learn that some of the women here reported having had a previous cancer diagnosis. 14 of the 112 during that first time period, and then 84 of the 258 during that last time period. Again, we don't know if they actually had radiation therapy, but we do know they had a previous cancer diagnosis. We looked at the maps of all of these, of the residents at diagnosis for all of these women. There were no unusual spatial patterns that we saw. We looked closely around the landfill, we looked throughout the community, and we looked at them with respect to population density. We also did a little analysis around some of these other risk factors. We know from the 2000 US Census that in Northampton, the percentage of women 25 and older who have at least a bachelor's degree or a higher graduate level degree was 49%. In the state, that percentage is 31. We also know that women in Northampton are having their first child later. In 1990, 28% of women diagnosed with breast cancer, 28% of women statewide had their first child after age 30. That was compared to 45% in Northampton. In the year 2006, 54% of Northampton women had their first child at age 30 or later, compared to 39% statewide. So that information does correspond with what we would expect from the literature. A very important finding from our perspective was when we looked at the percentage of Northampton women who were diagnosed with in situ breast cancer as opposed to invasive or malignant breast cancer. In Northampton, 33% of the women were diagnosed in that earliest stage, compared to 24% statewide. So what that tells us is that women in Northampton are getting screened early, and they're having breast cancer detected at the earliest stage. So that's very good news in terms of longevity and good screening. So the other cancer type that we looked at closely was bladder cancer in Northampton. Now, this was one cancer type where there was no statistically significant elevation. But what we did notice is that although the incidence was less than expected in that first time period we looked at, in the subsequent 3 time periods, it was higher than expected. So what we did is we pooled all of the data for the 18-year time period to look closer. And what we saw, actually I should back up and say that for males, bladder cancer across all time periods was as we would expect. I also want to point out that for bladder cancer, exposure to certain industrial chemicals has been linked with bladder cancer. They're particularly in the dye industry where they use certain chemicals called aromatic amines. We also know that smokers are twice as likely to develop bladder cancer as non-smokers. So in Northampton, we learned, well actually let me back up. According to the American Cancer Society, 70% of bladder cancer diagnoses occur in individuals above 65 years of age. 90% occur in those people who are 55 or older. In Northampton, 79% of the individuals diagnosed were over 65, and 91% were over 55. We also learned that smoking and occupation may have played a role for some of the diagnoses. There were 53 females diagnosed during that 18-year period, and we didn't have smoking history for 18 of them. But for the remaining 35 women, half of them reported being current or former smokers. And 7 of the 53 reported an occupation that may have put them at increased risk. Now, we also looked at those women diagnosed with bladder cancer who did not report being current or former smokers, to see if there was anything going on among non-smokers. And we also did this for people with no occupational history that could have put them at risk. And we did not see any unusual patterns, spatially or in time, in terms of their date of diagnosis. So now I want to focus on the Easthampton data. So we'll first look at Easthampton as a whole and then the census tract. Oh, I'm sorry. Those, yes, you're right. Okay. I'm sorry, I haven't talked about the census tract in Northampton yet. Again, I want to focus on those cancer types in the census tract that, where there was an elevation. There were 5 cancer types, and we talk about them in the report, where the incidence of cancer was just about as we'd expect. I will talk about lung and bronchus and kidney cancer briefly in the census tract, and then I want to focus mostly on the leukemia data. What I want to say about the increased incidence of breast cancer in this census tract was that the pattern closely mirrored the statewide, the citywide information, with the difference that women in this census tract actually, a higher percentage were diagnosed as in situ cancers. It was 43% in this particular census tract compared to 24% statewide. Briefly, for kidney and lung and bronchus cancers in the census tract, both of these cancer types were elevated in the most current time period. Neither was statistically significantly elevated, but in our report, we provide all of the information about what we learned when we looked at the maps and what we learned when we reviewed risk factor information. So I'm not going to go into detail on these right now, but again, I'd be happy to talk about them later. I guess in summary, there wasn't a consistent pattern with these. So I think I'll focus on the leukemia now. You can see in this table, for 3 of the 4 time periods, there were no leukemia diagnoses in the census tract. In that 92 to 96 period, there were 6 reported diagnoses when we would have expected 1. And this is a statistically significant finding. What we learned was that 4 of the 6 diagnoses were of a type of leukemia, AML, which is acute myelogenous leukemia. And so I want to talk first about those 4 individuals. AML is the most common type of leukemia in adults. And just like with cancer, where there are over 100 types, each one with its own set of causes and risk factors, leukemias are really thought to be as individual diseases as well. AML is the only type of leukemia where smoking presents an increased risk. 1 out of 5 diagnoses of AML is thought to be caused by smoking. We also know that exposure to benzene can put an individual at increased risk, as well as high-dose radiation. There's some evidence that previous cancer treatments, radiation therapy, certain blood disorders and inherited syndromes are associated with leukemia. And we know that for AML, the average diagnosis, or the average age at diagnosis is 67. So when we looked at the 6 individuals, we learned that 4 of the 6 had AML. 2 of the 4 with AML did report to be current or former smokers. And 1 of those individuals had had a previous cancer diagnosis. The pattern was not at all unusual. The females diagnosed lived throughout the census tract. And when we looked at the other 2 types of leukemia, one was the second most common type in adult, and the individual was diagnosed at an age that would be consistent with what we'd expect. Okay, so now I'm going to move on to Easthampton. In Easthampton, the census tract closely mirrored the town of Easthampton as a whole. For both of those geographic areas, bladder, breast, Hodgkin's lymphoma, leukemia, NHL, and liver cancers occurred about as expected. The three cancer types where there were elevations in one of the time periods or more were brain and CNS cancer, central nervous system cancer, kidney cancer, and lung and bronchus. Again, in the interest of time, I'm not going to focus on the kidney and lung and bronchus cancers. And that's because, again, there were elevations in one time period, but not in the other three time periods, so there was nothing consistently elevated. All of the risk factor information is in the report. What I want to talk about now is the incidence of brain and central nervous system cancer. Now, this was a type, again, that was not statistically significantly elevated during any of the time periods, but when you look at the data, you see that for three of them, there are more reported diagnoses than expected. It was that 92 to 96 where the incidence was lower. But we thought this warranted a closer look. Okay, for most brain cancer diagnoses, there's no clear cause. There's not a lot known about what causes brain and CNS cancer. The most established risk factor for this particular type of cancer is high-dose exposure to ionizing radiation, such as X-rays. There is evidence that rare genetic conditions and certain immune disorders can put you at increased risk. There's also some evidence that head trauma, occupational or exposure to certain chemicals like vinyl chloride, pesticides, petroleum products. There are certain compounds that are used as food preservatives and nitrosamines. And then there's some evidence, and again, it's debatable, but there was some research done that indicated that the artificial sweetener, aspartame. But the evidence is not as clear-cut with those risk factors as it is with the ionizing radiation. With brain cancer, we know that there are two peaks in incidence. There's a peak between birth and age 10, and then there's a lull. And then between age 25 and 75, there's another increase in brain cancer incidence. It's slightly higher in males. And we also know that 90% of brain cancers are of a subtype called gliomas. So in Easthampton, during this time period, those three time periods, there were 49, actually in this instance, we looked at the entire 23-year time period, and there were 49 individuals over that time period. We learned that the most common subtype among the Northampton individuals was glioblastoma, and among those, the most common type was glioblastoma, and that's what we'd expect from the epidemiological literature. Let's see here. We learned that in Easthampton, there were 6 individuals who were under the age of 19 that were diagnosed with brain cancer during that time, and I'm going to talk about them in the next slide. Let's see here. We also looked at the maps and did not see unusual patterns geographically. For women, there was some variability. Brain cancer was about as expected in incidence during the first 3 time periods, and then it was higher than expected in the last time period. In males, it was a little bit different. It was actually as expected in the first time periods, then it was lower, and then it was as expected. So I mentioned 6 of the 49 diagnoses were in children. They occurred over a 21-year time period. They were not grouped in time based on their date of diagnosis. They were all diagnosed with astrocytomas, which is the most common type of brain cancer in children. And next to leukemia, brain cancer is the second most common type of childhood cancer. And we did not see any clustering near the landfill or across Easthampton or in the census tract that we focused on. So this is the 1 mile radius that we looked at. In our report, we've got a table. There are 28 streets in part or whole that are in this 1 mile radius, and we've listed them in the report. The area is bounded roughly by Westhampton on the west, Ryan Road on the north, Ashley Circle and Loudville Road on the south, and then Sovereign Way up in that northwest corner, or northeast corner, sorry. What we learned is that there were 24 different types of cancer that were diagnosed among 113 individuals who lived in that 1 mile radius when they were diagnosed, and it covered 1982 to the time that we did our report, so it's up through very current data. We found that 60% of the diagnoses were the 4 most common types of cancer in adults: breast cancer, prostate cancer, colorectal cancer, and lung and bronchus cancer. There were 20 or so other types of cancer that were diagnosed, and we looked at each one of them. We looked at when the person was diagnosed to see if it was an age that would be expected. You know, the sort of things that we look for are, you know, was this cancer diagnosed among very young individuals when that wouldn't be expected? We did not see any unusual patterns when we looked at maps and when we drilled down to look at small neighborhoods in this 1 mile radius. We found that the average age of diagnosis was 63 years of age, and that 82% of the people diagnosed were at age 50 or older. Let's see here. We also learned that smoking may have played a role in some of the diagnoses. 27 out of the 35 people for whom we had smoking history and who had a cancer for which smoking is a possible risk factor. 77% of those individuals reported to be current or former smokers. Okay, I mentioned that we looked at birth defects data. The Massachusetts Department of Public Health has a birth defects registry, and we work closely with them. The first year for which they started to collect data is 2000, so we had 4 years worth of data. They're through 2003 is their last year. And we looked at the prevalence of birth defects within children, birth defects diagnosed within the first year of their lives. And we looked at the spatial distribution. We learned that over that 4-year period, there were 16 babies and children diagnosed with a birth defect in Northampton, and there were 12 in Easthampton. Now, if you look at these rates, you'll see that the rate in both communities is higher than the statewide rate. But when we calculated the confidence interval, neither one was statistically significantly different and most likely represents natural variation in the rates. We worked with a clinical geneticist at the birth defects registry and reviewed these data closely with her. We put on a map where, based on the maternal residence during the maternal residence of birth, we looked at the maps. She, who's an expert in this area, looked at the type of birth defects and did not, and unequivocally said she did not see anything that looked unusual to her. We also looked at the prevalence of low birth weight births in Northampton and Easthampton, and we had 6 years worth of data available to us. And for both communities, the prevalence of low birth weight births was statistically significantly lower than the state as a whole. Our report also also contains information on asthma, as I mentioned. We have a pediatric asthma surveillance program in Massachusetts that's run out of our program, and it's based on reports that are sent in to us from school nurses across the state. And the report contains asthma prevalence numbers for all of the elementary and middle schools in both communities. But I wanted tonight to focus on the Finn School because that is about 1.5 miles from the landfill. And what we found is that for the first 3 years of reporting, asthma prevalence was not different really from the state. For this most current year, it is statistically significantly elevated. And so I actually called both the school nurse lead in Northampton as well as the nurse at the Finn School because I wanted to know if there was something unusual. Why did we see higher rates in this most current year? And both of them felt that the asthma prevalence really is quite stable. But what they think is happening is that they revised the medication and the health reporting forms, and they think that parents are simply doing a better job of reporting. We also have access to hospitalization data from the Massachusetts Division of Healthcare Quality and Healthcare Finance and Policy. They collect patient-level information on hospital discharges across the state, and so we looked at data for asthma hospitalizations as well as asthma-related conditions for both Northampton and Easthampton for a 6-year time period, and with the exception of 1 year, the rates of hospitalization in both communities were very similar to the statewide rate. In Northampton in 2001, there was an elevation of borderline statistical significance, but it did not persist over time. Children in Massachusetts 3 years and younger have annual blood tests for lead in their blood. It's through the Childhood Lead Poisoning Prevention Program in the Health Department. And we worked with them to review lead test results for Northampton and Easthampton. And we compared what we saw in the census tracts around the landfill to the city and town, the communities as a whole, and then to the statewide levels. And we did not see any differences between the blood lead levels in these communities, or in the census tract areas compared to the state and the communities as a whole. I mentioned that we did look at autism information. There are no registries in Massachusetts, or in most states for that matter, for most chronic diseases, so it's very hard to evaluate the incidence or prevalence of a lot of chronic diseases. The reason we could look at some autism data is that in 2001, the Department of Education started collecting information from special ed departments in schools across the state on autism. It's a limited data set. It doesn't include all autism spectrum disorders, but it's what we had to look at. So we looked at 3 years worth of data, and we found that in Northampton, the prevalence of autism was lower than the statewide prevalence in 2 of the 3 years. And then in the third, it was higher, but again, it was not statistically significant. And we don't have address information to look at individual level data. But we do know that between 10 and 14 students were diagnosed as autistic during that time period in Northampton. In Easthampton, the prevalence of autism was higher for the 3 years. Again, these weren't statistically significant differences, and we know that between 9 and 14 students in Easthampton were reported with autism. So based on all of the information that I talked about, we felt, and again, looking at the rates, looking at the spatial patterns, the temporal patterns, looking at all of the risk factor information, that we did not find any red flags. We did not see any commonalities that made us think that there was something unusual going on in the incidence of disease in the two communities. What we did say in our report that we will continue to monitor cancer incidence in both communities. We work closely with the Massachusetts Cancer Registry, and we use their data on a daily basis. We have a follow-up database, and when we do these evaluations for communities, we put in reminders to us to check the data in another year. I didn't mention this at all in my presentation, but we have been working at the request of some residents as well as the city officials to look at some of the environmental sampling data that have been generated. But again, that's not the focus of tonight's meeting. I really wanted to just present all of the health information that we gathered. So I'd be happy to talk about this with you when the time comes. Thank you.
Thank you, Jan. You did a tremendous job getting a lot of information out there. And I imagine that there were several points of technical clarification that people feel that they're going to need.
Can you speak into the mic?
Sure. I hope that people took notes on the questions that were generated for them by that presentation. If it seems that it would be helpful for a broad summary of the approach that they took and the conclusions, I think that we'll get that coming out in the questions, and we'll ask for, is there a way that we can kind of concisely say what was found? But I think for now, I would like people to kind of stretch their legs. We're running pretty close to schedule. If people could be back here in 10 minutes, we'd like to start pretty quickly with the next presentation. Get yourself some water, clear your head, make sure you get some blood going around you. We've got 2 more presentations. That was a tremendous amount of information, and I feel as if people aren't going to be able to stay until 9 o'clock, they may still want to have their questions addressed. So what I'm going to offer is, if you know that you're not going to be able to stay until the question period, and you had questions that came out of Jan's presentation, if you want to bring them to me in writing, I'll make sure that they get asked and addressed during the question period, and then this meeting is being taped, and we'll find a way for you to be able to review how those were responded to. So just come up to me quietly if you need to leave with your written question. And with that, let's get started with our next presentation. It'll be about half an hour long, and then we're going to have about a 10-minute presentation from Dr. Clapp, and then we'll have questions after that. So this will be a slightly shorter chunk of time. And our next presenters are from Gradient Corporation. They were asked to do answer a slightly more specific question than the Department of Public Health. And the speakers will be Julie Goodman and Lawrence Romberg. Sorry.
And I will start. Well, thank you for the opportunity to talk to you today about our analysis. I know this is a lot to come at you. You've heard just an hour with lots and lots of data. We're going to try to not show you every piece of data and analysis that we've done, but show you some highlights. We have, of course, all of our results in our report. I'm going to just start out briefly and make the introductions. And Julie Goodman, who is the expert and the conductor of this analysis, will then take over. Next slide, please. First of all, who is Gradient Corporation? We're an environmental consulting firm and risk sciences firm. We're in Cambridge, Massachusetts. We also have an office in Seattle, but we too have come from Cambridge. We've got about 80 people in our company. And we work on environmental risk and toxicology issues and epidemiology and product safety issues and so on for a variety of clients, for government and industry and private sector, public sector, nonprofit organizations. I myself do a lot of work with the US EPA on chemicals and also on risk assessment methodology. And as I say, we've got a wide range of practices that we work on. What we've been asked to do here is some work on epidemiology. Next slide, please. So what are the goals of our study? It's to determine whether there's an increased risk of incidence of cancer in people living in Northampton or in Easthampton, and especially those living near the landfill. We did maybe a little bit more complex geographic analysis than the state did, but we were using essentially the same data. We had a little bit of a different task. First of all, we were looking just at cancer. We were not looking at the autism and the other kinds of non-cancer endpoints. We were strictly looking at cancer issues. And our job was to look at the cancer data and say, is there any evidence that there's an elevated risk of cancer in this area? We did that in methods that you will be familiar. In some of the slides we will show, you will see are some of the same methodological approaches that the state did. But this was a parallel analysis. We did it independently, other than them helping us get the data, which as a non-government organization, we needed some help to get access to those data. We did this analysis independently. We have not seen the state's analysis until this very moment, just as you did. But I think you will find we came up with very similar kinds of conclusions. And so now we're going to present our findings here. Now, because our analysis was really to try to look to see if there were any issues and if there were any patterns that would be requiring further investigation, in some ways our details of analysis are maybe more limited. We were looking for those patterns, and if there were patterns to be followed up on, then of course more work would be necessary. As I think you found, the state said they didn't particularly find any patterns. That's in accord with the kinds of analysis that we came up with. And so, since we haven't perhaps explained our methodology as fully as the state did in their more comprehensive report, we have a chance to explain it to you now. And so with that, I'll give it to Dr. Goodman, who will explain our particular results.
Thanks. So I'd just like to start by taking a step back and defining what is epidemiology. And epidemiology is the study of the distribution of diseases. Basically, there's what we call a background rate of disease. And what this means is that everywhere you go in the state, in the country, in the world, people have cancer. And why you do an epidemiology study is to see, is the rate of cancer in a certain area or among a certain group of people higher than you would expect, and higher than this background rate. And if it is higher, then it's possible that there's some local factor that's contributing to disease incidence. So what is cancer? Cancer is any malignant growth or tumor that's caused by an abnormal and uncontrolled cell division. And it's important to note that cancer is not one disease, it's actually many diseases. So cancers in different organs are all different diseases, and even cancers in the same organ can be the same disease, and the state talked about that, or Jan talked about that before, like different kinds of leukemias. The development of cancer can often take decades, and cancer is actually a lot more common than people realize. About 1 in 3 people in their lifetimes will get cancer in the United States. And as Jan talked about, cancer rates vary by age, race, gender, risk factors, and cancer type. So there are many known and potential risk factors for cancer, and I've divided them here into 3 categories: internal factors, external factors, and lifestyle factors. So internal factors are sort of biological things, unique to all of us: our age, whether or not we've inherited genetic mutations, hormones, immune conditions. Then there are external factors, like whether or not we smoke, if we're exposed to certain chemicals, radiation, or infectious organisms. And then finally we have lifestyle factors. Things like poor nutrition, physical activity, and obesity are all known to contribute to cancer risk. I also just wanted to take a minute to explain the difference between cancer incidence and cancer prevalence. Cancer incidence refers to new cases of cancer appearing over a specified time. So for example, over a year. So in 1 year, how many new people are diagnosed with cancer? And this is different than cancer prevalence, which is at any period of time, how many people have cancer. And the state has an excellent cancer registry and has information on cancer incidence, so we were able to do our analysis using cancer incidence data. So this is from 2002 to 2003, so it's a few years old, but did want to just show you, we have rates of all cancers in the United States, Massachusetts, and Northampton. And in all three areas, rates are higher in males than in females. And rates are higher in Massachusetts generally than the United States. But they're actually lower in Northampton on average than in Massachusetts. So what we were looking for are disease clusters. And a cluster is defined as a greater than expected number of people with a disease that occurs in a group of people in a specified geographic area over a period of time. And disease clusters may be beneficial for identifying harmful agents. And I think a good example is women who took DES a few decades ago. Many of their daughters had vaginal cancer. And this was unexpected, so it was a group of people that had a cancer that was increased over what was expected, and they were able to figure out what caused that cancer. But when you're looking at clusters, you really need to evaluate the patterns of cancer and determine whether or not it suggests a local effect. So there are several hallmarks of true clusters, and they don't all have to be met, but these are generally true. First is that there's a large number of cases of a specific disease. As I mentioned, cancer is not one disease but many, so you would expect an increase in specific cancer types for a cluster in general. Also, it's much easier to identify a rare disease rather than a common disease as a cluster, because you see common diseases more often. Another thing is an increased number of cases in an age group that's not usually affected by that type of cancer. As I mentioned before, the vaginal cancers in these young women. This type of cancer generally wasn't seen at all, but when it wasn't in young women at all, so that was a red flag. Clusters often occur in well-defined occupational or medical settings, so in maybe refineries or factories where people are all working with the same kind of chemicals. And finally, they often occur with intense and sustained exposure to an unusual chemical, occupation, infection, or drug. Just to give you some statistics about cancer cluster investigations, there's about 1,000 inquiries a year to state and local health departments, and about three-quarters of these are actually resolved by phone. And when these health departments follow up, usually they ask questions like the number of people affected, their age, the cancer type, dates of diagnosis, and other factors. And what they do, and what we have done, and the state has done, is compare cancer incidence in this region versus that in the state tumor registries. And when this happens, generally 5 to 15% of the time, there's what we have a statistically significant cluster. Meaning, based on statistics, there's more higher incidence of cancer than the background rate. But it should be noted that oftentimes this can be due to statistical chance. And not always, and certainly that's why you look and you look deeper, but I did want to bring up that point that it can happen. And I think a good way to think of that is that if you look at every person that has cancer, they don't all live equidistant from one another. For example, they don't all live 1 mile apart. So what that means is that you're going to have areas where there are fewer people with cancer, and then you'll have areas where there are more people just by chance. And so really the whole point of a cancer cluster investigation is to determine if you do have a cluster, is it likely just due to statistical chance, or is it because there is some local factor? And that's why we set out to conduct this analysis. Oh, sorry. So, basically, so the way we go about investigating a cluster is first, it's a systematic process for determining whether a cluster is due to chance or if these individual cases are related. We then determine if a perceived cluster is composed of particular diseases. We then conduct a statistical analysis to determine if the observed number of people with disease is higher than expected, and finally determine if the cases occurred over a similar time period. So there are 3 potential outcomes. First is that you see no incidence of similar diseases at an excess rate, which is what you hope for. The second is that you see a higher incidence, but it's because of the statistical chance I just talked about. And then finally is you see a higher incidence of disease that could be linked to a local, biological, or chemical cause. And if that's the case, you want to do further analyses to try to figure out what it is. So Gradient actually looked at different and more cancer types than the state, and this was essentially at the request of City Councilor Marion Labarge. She had basically requested we look at cancer types for two reasons. The first was that she knew of people in the community that had cancer types, and she wanted us to look at those specific cancer types. And the second is that citizens, based on, for whatever reasons, articles they've read or things like that, were specifically concerned with specific cancer types. So we were able to look at all of those cancer types. And so I have a list of them there. There are 18, and we were really fortunate that we were able to get the data from the state so that we were able to analyze these cancer types. So just to give you an overview of the study that we conducted, which you'll see was very similar to the state's study, we examined cancer incidence rates near the landfill in Northampton and Easthampton, and we determined whether the cancer rates were higher than these background rates. We analyzed all cancers together and each cancer separately, and we did this based on the data from cancer incidence from 1982 to 2004. And as I said, these data came from the Massachusetts Cancer Registry. The data for the state and for Northampton and Easthampton all came from the Massachusetts Cancer Registry. And to get the number of residents for each locale we studied, we got the census data from the 1980, 1990, and 2000 census and extrapolated to the years of interest. And we calculated the cancer incidence per unit of population in each locale. And as Jan mentioned before, age is a very important factor for cancer. And as did the state, we adjusted all our analyses for age to make sure that we were comparing apples to apples. So all of the numbers I'm going to tell you about were adjusted for age. And we also calculated standardized incidence ratios, or SIRs, like Jan talked about, to determine whether rates are higher than expected. We looked in men and women separately, and men and women combined. As Jan said, we looked in the same time period, so that was 1982 to 1986, 1987 to 1991, 92 to 96, and then 1997 to 2004. We actually looked in census blocks near the landfill, and I'll show you a map to show you what I mean. And we looked within a 1 mile radius of the landfill. And we also did, we looked at spatial patterns of cancer using GIS systems to determine whether there are clusters as well. So I hope this equation looks familiar. It'll be a test. But essentially, just to show you again, to remind you what an SIR is, I put here the control group exists on paper, and by this what I mean is we're comparing rates in Northampton to the state as a whole. So we're not comparing a group of people in Northampton to a group of people in another similar city. It's actually compared to the state as a whole. And so we divide the observed incidence, so the observed number of cancers, over the expected. So that expected is essentially what we call the background rate, what you'd expect the background to be based on the state. And you multiply by 100 to make it sort of equivalent to percents. So if you have 100, it's like 100%. The number of cancer cases you observe is what you'd expect for the background rate. So essentially there's no effect likely, no local risk factor. If it's significantly above 100, it means there could be an increased risk. And if it's significantly less than 100, it means there's something is potentially protective. And I mean, just to give you an example of that is if there's something like exercise or eating fruits and vegetables or some factor that's known to help prevent cancer, that would give you an SMR of less than 100. So here is our map of Northampton and Easthampton, and it's colored by census census tract. So there are 10 census tracts in the two cities combined. And, yeah, that should actually say tract, not block, I'm sorry. And we have the landfill right here. So what we actually did was we calculated SIRs for every census tract in Northampton and Easthampton. So we could determine whether or not there were increased risks both in the census blocks near and around the landfill, but also in the city as a whole to see if there were any patterns. Now, what we did within the 1 mile radius is a little different than what the state did. The state actually looked at the individual people, saw what cancers they had, and did sort of a more in-depth analysis of each person. What we did instead was we actually calculated the population within a 1 mile radius using what's called a census block. So a census block is what the US Census uses to measure how many people live in given different geographic areas. So we were able to basically figure out how many people lived within this 1 mile radius and calculate an SIR for that area. So this is just one additional analysis to all the other ones that the state and that we conducted to sort of just look at the data in a different way. And our report was submitted to the city, and I'm sure it's available to anyone who'd like to see it. I only have one table here today, because I don't think you'd want to see 50 like this. But I just wanted to show you what the data looks like. So, and I just pulled out this Northampton city from 1982 to 1986. And essentially we have a list of all the cancers that we looked at, the observed number of cases, of incidents, of new cancer cases in that time period, and then the expected number, or what the expected background rate would be. And then we calculated this SIR. And again, as I said, if it's strictly speaking 100, you'd say no risk, greater than 100, there could be an increased risk, and less than 100, potentially protected. But as Jan talked about, there's a natural variability in the state, and so you can't take the exact number at face value. What you do is you do a statistical analysis to sort of get an idea of the variability of where this number probably lies. So what you do is conduct this, calculate a 95% confidence interval, we call it. And what we do is we essentially look at not just the SIR, but this confidence interval to see whether or not there's an increased or decreased risk. But I think most importantly is, so we did this, I said, for Northampton and for Easthampton as a whole for 4 time periods. We did it for men and women separately and combined. And we did it for all the census tracts. So the idea is you take a step back and you look at everything together. So if you see there's some, increased risk, but it's only in females and only in 1 time period, it's not, let me rephrase that. If you see an increased risk in females in all 4 time periods, then that means there's a pattern of effect, and there's likely, or there could be some local source that you want to look at. But if you just see an increase in females in 1 time period, that means, and there's no pattern over time, that suggests that is sort of a statistical anomaly rather than that there's a local cause. And I also want to say that like the state, we didn't just look at statistical significance. So it's not just if the statistics say so at this time point and not others, then we're good. You still look for patterns whether or not the statistics actually put you above or below the threshold. I didn't lose you all there.
And you look for geographic patterns.
Right, and then I also, and doing this too, we look for geographic patterns to see if there was anything within the census is closer to the landfill versus farther away. And just to give you our overall results in a slide, when we looked within a 1 mile radius from 1997 to 2004, we didn't find any elevated cancer rates. When we looked in the census tracts, we found that some cancers were statistically significantly different than expected, sometimes higher, sometimes lower, in some time periods and in some census tracts, but they did not persist over time. So we saw no patterns of effect, either statistically or non-statistically. And finally, track 8222 is where the landfill is. And we found that all cancer types occurred at expected rates, except for leukemia in women between 1992 and 1996. And this was not observed in men or in other time periods. So again, because there was no pattern of leukemia, we interpreted it as this finding in this time period was more likely a statistical anomaly rather than indicative of it being caused by some local factor. So the last analysis we did was a different type of geographical analysis. Again, just so we could look at the data in another way. And what you see in this first map on the left is the population based on the 2000 census tract. So where you see the darkest color is where the most people live. And the reason for the borders is that's where these census blocks are. That's where the census actually measures where people live. So you can see that the most people live around here in Northampton and here in Easthampton and maybe at the border. And here we have the landfill and the 1 mile radius, and we have a lot fewer people living there. And what we have in the second map is what I call the density of cancer cases. So as Jan mentioned, because of privacy laws, we can't tell you where individual cancer cases live, but we can sort of show you the trend of where they are. And what you can see is it mirrors where the most people are. So where you have the highest population is generally where you have the most cancers. Same for down here and down here. And again, I'm trying to think of the right word. I don't want to say blob, but the idea is it's not exactly, where each cancer case lives. It's sort of a statistical representation, so you can get a general sense. But if you divide where all the cases are by the population, you get this map here. And you can see that around the landfill, you don't have a higher proportion of cases, which is suggesting that there is no statistical cluster of cancer cases around the landfill. So to conclude, we found that the incidence of cancer rates of cancers of all cancers combined in the 18 we analyzed separately in Northampton and Easthampton, the cities as a whole in the census tracts and within 1 mile around the landfill are not higher than expected based on the cancer incidence rates in Massachusetts. And there also does not appear to be an increased incidence of any cancer type examined in the area surrounding the landfill. So thank you very much for your time, and I look forward to your questions after.
Thank you very much, both of you. And we're going to slide right into the next presentation. It needs to be loaded onto the computer. It'll be just a minute.
While we're waiting, I'll just tell you a little story, I guess, about myself. My name's Dick Clapp. I work at the Boston University School of Public Health. I used to work at the State Health Department. In fact, I started this cancer registry. I was the first director, hired in 1980. And we set it up in order to see if there were more Woburns in Massachusetts. The reason was because of the Woburn childhood leukemia cluster. That's why we set up the state cancer registry, to see if that was going on somewhere else, or even whether it continued in Woburn, which it did, and then it went away. So it's like, if we were to look at the Woburn childhood leukemia pattern over this time period, there would be a period of very strong elevation in the early time period, and then it went away. Actually went below expected based on the statewide average. But that variability didn't say to me or to anybody else, actually, that wound up looking at it, there was nothing going on. It actually said it was going on, and there was presumably exposure that caused that was shut off. And so I wanted to make that point, that it is partly, a cancer registry is partly to look at patterns of cancer in communities, but it's also to look for causes. That's the other part of it that I think we need to sort of keep our focus on. There we go. That's me. And I have only heard the State Health Department's presentation tonight, so I'm in the same boat that the rest of you are. I'd like to see the report itself, which I understand is here and can be distributed later this evening. But so I don't have much to say about the State Health Department report, although I'd like to have a chance to look at it. So my comments are limited to the gradient report. So as I said, we set this state cancer registry up to see if there were more Woburns. Is Jonathan Hart here by any chance? I know he lives in Northampton, so you probably all know the story, even if you didn't it's also part of a, yep,
Can you just hang on one second? I want to see if I can, it looks like it's being cut off. Yep. So I just want to, sorry.
probably doesn't matter, but I'll keep talking.
It's not on the screen, so it might have something to do with it. Sorry.
Right. One other thing to say about the State Health Department report, which you heard tonight, which is very thorough. I mean, it's a close look at all the data that's readily available to the State Health Department. And so I commend Jan for having gone, and her staff for having gone to all that work. It's as thorough as you can get with the existing data. And I used to work with Jan, and I know her to be a thorough and competent person. So I think you're in good hands with that as far as that goes. I think there were some interpretations that were made that I'd want to look at the report itself before I necessarily agreed with the interpretations. And that also applies, I guess we should now go on to the next slide. So for the overall picture that I guess both of the previous presenters have said, that overall cancer, all types combined, has been lower in Northampton than would be expected based on the statewide average. And I guess that is good news. It's still a lot of cases. It's sort of, any cancer is too much cancer, I think, in most people's minds. And we do live in a state where there's more cancer in Massachusetts than there is in most other states. So although, for females at least, the rate of cancer in Northampton, I believe, was slightly less than the state average. For males, it was not. And so it's an overall, it's a sort of neutral story with respect to all types of cancer combined. But there were examples in various of the tables of excess cases in Northampton of multiple myeloma, kidney cancer, oral and cervical cancer in females, and then multiple myeloma in males. Now, several of those, I'm not sure the previous speakers referred to it, but multiple myeloma does have environmental causes, and solvents is one, and particularly benzene. And so it's not one of these that sort of nobody knows what causes it. It's one that has been studied quite a bit. It's not to be ignored, I think, when you're concerned about environmental exposures. And then there were no statistically significant excesses overall, except for a statistically significant deficit or decreased incidence of prostate cancer. And so that's another way of saying that there's a lot fewer cases of prostate cancer in Northampton men than would be expected. And that's probably not something that is just a down fluctuation that occurred in some particular time period. I want to say a few words about statistically significant. There's a difference between statistically significant and a public health significance. And another way of saying this is that statistics are human beings with the tears wiped away. So I would say lower prostate cancer in any population is, and it's been low enough so that it's probably not just due to some random fluctuation down. That is good news. But if you don't have statistical significance, and that is really a mathematical calculation, that doesn't mean that there's not public health significance. And it doesn't mean that cases that, for example, are more than you would expect, even if not statistically significant, are ignorable. So I think that's the next slide. And this is really the meat of what I wanted to tell you in response to the gradient report. I think actually the most important, from the point of view of the landfill, the most important analyses are the ones within 1 mile, the people who live within 1 mile of the landfill. And there I think there are some important points that need to be made, even if they don't reach the level of formal statistical significance. So, for example, I'll just say that there was the leukemia, which both speakers have referred to in Census Tract 8222. That's actually too big an area to look at, I think, to understand what's going on. It goes all the way over to the east end, it looks like, or about to Route 91. So that's not the whole, that includes a lot more people than were exposed to whatever might have been coming off the landfill or in their water from the landfill. But there is an excess of non-Hodgkin's lymphoma in the landfill area, and that's in females. If you look at males and females combined in that particular table, actually that's the last table in the gradient report, which hasn't been put up on the screen. But there were 4 cases of non-Hodgkin's lymphoma and 2 expected in both males and females combined. So that ratio of observed to expected, that's 200. That's an SIR of 200. If you look at just females, there are 3 of the 4 cases were in females. 0.8, less than 1, was expected. So that SIR is 375. And I put the 95% confidence interval there to show you that this on the table, by the way, is called NC, not calculated, where you can calculate it. I mean, when I first started the cancer registry, we put all of those calculations in the report. And it's, for some reason, a subsequent decision was made not to calculate case or SIRs when there were fewer than 4 cases. There's no public health reason for that. There's this balance between sort of unnecessarily alarming people because some of these SIRs are really high, or false reassurance of people by saying, well, we didn't even calculate it because it's too few cases to be concerned about. And I think that's a balance, and I would argue in favor of giving people the data. They can decide whether it's unnecessarily alarmist or falsely reassuring. I just want to show you that the female SIR for non-Hodgkin's lymphoma is 375, calculated in the same way, and the confidence limits go from 77 to 1,095. So it's very wide confidence limits, and it doesn't officially meet the convention of statistical significance. So I would say that from my point of view, the jury is still out on what's of concern around the landfill. There could be further studies done. In fact, talking to patients, finding out more about residential history, as Jan pointed out, that's the cancer registry collects the residents at diagnosis. But it's of some interest to know, well, are these people who just moved there and then got diagnosed with cancer, or have they been living there for a long period of time? That can be easily done. And so some additional, I would say, additional inquiries would be necessary before I would feel like I would give this a clean bill of health, and I'm not at that point yet. So I wanted to share that with you as at least my comments on the gradient report. And I would urge you that statistical significance is not the be-all, and I think both speakers have said this, it's not the be-all and end-all, and that you only talk about things if they're, quote, statistically significant. If there are more cases than you would expect in an area, you want to find out why. And the reliance on statistical significance is, I think, misplaced in this kind of work. This is what's called descriptive epidemiology. I think I'll stop there and be glad to take questions with other people.
Thank you, Professor Clapp. I wanted to make a quick announcement that the Department of Public Health study is available. There are reports that we're going to have available. I think what I'll do is ask if someone can put the box of that out in the hall. So for people who need to leave early, you can get one on your way out. Otherwise, people can pick them up at the end of the meeting, because I don't want to waste time right now with a lot of disruption around it. We're about to enter the question and answer period of the evening. And you all have given great attention to the speakers, and I want to extend great thanks to the speakers for having presented as clearly as you possibly could, and for all of you for your attention. And now we're going to flip that, and we're going to ask for great attention from the presenters and the researchers, and see if you can, to the best of your ability, really hear what the questions are, what the concerns are, and give them as much attention as they gave you. And I also want to mention right now that we've heard a lot of science and some commentary on science, and just to remind people that science answers particular questions in particular ways at particular times. And that's what we have come here to hear from, and that's why we've come here tonight to hear about that. But these studies don't answer all people's questions, and they don't speak to everyone's experiences. And that can be challenging to now take this information and try to relate it to what your experience has been and respond to it from that place. So I just wanted to acknowledge that that's difficult. And I would ask people, when you ask your questions, to try to focus on questions that clarify what it is that you heard, that share any concerns that you have based on your own experiences in response to what you've heard. I also encourage you to speak for yourself and not for others in the room. and to try not to attribute motives to other people in the room. I also would like people to identify themselves as they speak, and again, to be concise as you possibly can. I'm going to be trying to hold people to no more than a couple minutes at the mic. And then I'm going to ask everyone, even those not asking questions, but those listening, that these issues are very, very personal and very sensitive to people. And there's nobody in this room, I guarantee you, who hears the word cancer and doesn't have a very personal experience that comes to mind because of that. And everybody's experience is their own truth. So I'd like to give people a lot of respect and care when they come to the mic to talk about things that might be very sensitive to them. I think that's all that I needed to say now, and I'm going to ask that people line up at the mic. Nobody did bring me written questions, so I hope that that means that everyone who had a question was able to stay, which is great news. We're going to allow pretty close to an hour of time for this public comment period, and then we're going to take another official short break and then turn it over for the board to conclude their meeting, and they will use that time to officially present questions to the researchers from the board members. Are there any questions people have right now about format and how we're going to do the questions and answers? Okay. I will also remind you that I'm going to be on that side of the room right now with a pen in hand, and when things arise that we're not able to address tonight, I'm going to keep a record of that so we don't lose track of people's concerns that we can't answer tonight. Okay? Thank you. Please introduce yourself as you ask the question.
Hi. Hello. I'm Amy Hughes. I'm a teacher in Northampton and Easthampton after-school programs, and I live on 892 West Hampton Road, which is in your little 1 mile radius. I just moved there in March. And just wanted to say that I guess my concerns are threefold. The last speaker mentioned the non-Hodgkin lymphoma was pretty high for females. I don't know if it was within statistical, what did you call it, statistical significance, thank you. But I don't know what the causes of non-Hodgkin lymphoma is. So that was one thing, and then just really briefly, the long-term effects on children, and also if this is going to be built over an aquifer, are we going to get our drinking water from somewhere else? Because you can't really drink water that's polluted. So those are my questions. And maybe you can't answer them all, but that's my concerns.
I just want to make sure that that middle question that I understood it so that the presenters do. You say long-term effects on children. Can you clarify what you're asking?
Yeah, if you looked at somebody who grew up in the 1 mile radius from birth to like 40, maybe they lived in the same house. I don't know. Would they have developed something by age 28 or 33 or something like that? Is there any way to kind of focus on these people that live within the region? Like, what if I want to have a kid? I live in this area and they grew up there, and am I going to see them die at 22 because of some random ambient pollution floating in the air or in the aquifers? That I don't have well water, but anyways, some people around there do, and they would probably be concerned for their children too.
Okay, so we're going to take these. I hear 3 questions.
Yes, you do.
So we'll take all 3.
Thank you guys very much.
The first was, are there known causes of non-Hodgkin's lymphoma? Is that correct? Is that your question?
Yes. Is it at all related to landfill stuff specifically too?
Or the known toxins, chemicals, exposures associated with landfills? Is there anyone on the panel who wants to answer that?
I do have some, in the health department report, at the end of the report, we have summaries of risk factor information for the 9 cancer types that we looked at. What I can tell you by quickly glancing at this, it's a lot of information, and I apologize. I don't have a lot of this on the tip of my tongue, but I can tell you that for non-Hodgkin's lymphoma, it is more common in people with compromised immune systems. There is a genetic predisposition to non-Hodgkin's lymphoma. There's evidence that certain viruses can put you at increased risk, like the Epstein-Barr virus. There's also evidence that if you have a certain bacteria, Helicobacter pylori bacteria, which is associated with stomach ulcers, that can put you at increased risk. There's some evidence that exposure to chemicals in the environment, particularly herbicides and pesticides, can put you at increased risk. Let's see, there's other compounds where there's not as much evidence. I mentioned those food preservatives, nicosamines, there's been some evidence of that as well. So, there's a mixture. There's some genetic components, there's some viral etiologies, and then there's some environmental contaminants as well.
Just to add service to that, too, I think people working dry cleaning, for example, have an increased risk of, is this too loud? People who work in dry cleaning establishments have an increased risk of non-Hodgkin's lymphoma and kidney cancer.
Is there anyone else on the panel want to speak to that? Okay, so the second question is, have any results emerged that would create concern about long-term exposure to children as a result of the landfill? And please tell me if that does capture your question.
Well, I just didn't know if any of the landfill ambient pollution would qualify as some of those environmental chemicals that you said could potentially contribute to the lymphoma.
Well, as I mentioned, the reason we picked the cancer types that we did is because there has been monitoring at the landfill, and there have been heavy metals detected in the groundwater, and there have been some recent sampling of sediment in the area. So, and there's also been some organic solvents detected. These are not unusual in landfills. Those are common landfill contaminants. What I should say, when we focused on looking at the health data, our department did look at the private well monitoring data that was collected, and we did a close look at that, and we wrote a report that summarized it, and we sent it to the private homeowners who have wells. So that's been looked at, and Jessica actually has, probably the data is much closer to her, but they were not found at levels, there was, in general, they complied with drinking water standards. There were a couple of contaminants right around the drinking water standard, but in general, there were high sodium levels, as I recall. But there were a couple of metals that were found around drinking water standards. But our task for the health department anyways was really to see what the health data told us.
And then, is that all right? Is there anyone else wanting to? And then I think, again, tell me if this is not your question, but I understood your last question to be, is the city considering finding an alternative drinking water source to the existing aquifer? Is that your question?
If you can't use the aquifer because the landfill is built on top of it, where are you going to get the water for us to drink?
That's a question for the city.
Yeah, but I don't get it.
Okay.
It's a really serious question.
Why is it a question for the state?
I'm sorry, did I say state?
Yes.
City.
She said city.
I said city.
Maybe
Okay.
it's my ears.
That's all right. Well, I think we'll see if, is there someone from the city who can summarize? I know that there has been a recent public forum that has looked at the issue of groundwater. I was not involved with that, but if there is someone who can summarize, in a nugget what that was about, or if it addressed this question, I think now would be a good time to do that.
Can I suggest that you put on your list? Could I just make a comment there? Those are really good questions, and as as Sarah mentioned, we did deal with this issue at the last public forum. I'm afraid to open this up again because we're going to lose focus on the issues that we have experts here to respond to. So I'd be very happy for the board and the department to address this at a later time. But let's try. It'd be best for everyone and best use of their time if we could focus on the health issues right now.
When, is this stuff on, like, the last meeting you had on some kind of, like, documented, like, TV thing?
Yes,
or-
it's on TV. Right.
So we can find it
For Northampton.
And
It's at the Forbes
Yeah,
Library.
Forbes Library.
Forbes Library, thank you.
Okay, thank you very much for your patience.
Hello, my name is Andrew Woodland. I'm a resident of 907 West Hampton Road in Northampton. I want to thank everyone for giving the presentations today. That was some great information. I also want to thank the board for providing this forum. This has been great. My questions relate to interpreting what we've heard tonight and how can we use that information to think about what's coming down the pipe later on. I guess one of the questions I have is for those who have worked in epidemiology, I wonder if you've studied other landfills. Are there typically clusters of cancer or other disease around landfills? And if so, when during the lifespan of a landfill does that become evident? I'm wondering, is it possible that, with the increased activity at the landfill over more recent years, if we might not see some of the effects of that until later on in the landfill's life cycle, so there is still a danger, even whether we have or have not seen danger thus far.
Well, one piece of information, I guess, that might answer part of your question is that my understanding the landfill's been in operation since about 1969 or so. And most cancer types, this is not true for childhood cancers, but for adult cancers, they have a latency period, a development period, and that can range anywhere from 10 to 40 years. So, at this point, say you go 10 years from 1969, that brings you to 1979, not too far from 1982. So we've been able to look at the data for 82 through 2004, and actually for that area right around the landfill, more years than that. But I feel like we've been able to look at a good chunk of data, in terms of time and when you might expect to see some elevations that really we can't explain in any way. And, to be honest, we didn't see anything like that. We didn't see those red flags we take this very seriously. We do this throughout the state, and we can't always say, what was interesting to me when we looked at the Northampton data, and, I think it's very important, like Dick said, not to just look at statistics, and we didn't do that. We pore over these data, and we look at these maps very carefully, and we did not see any red flags. We did not see clusters in any neighborhoods that would make us worried that we were missing something. And this is not an exact science, as you can probably tell, but I feel like we really did take a pretty hard look, and we did have a good almost 25 years worth of data to look at. So.
One other thing to say is that there have been a lot of studies of people who live around toxic waste sites. Woburn is an example of that. There's actually 2 toxic waste sites in Woburn. So it wasn't really about the landfill in Woburn. But there are some studies in the literature. There's one that's in Helsinki, and there's actually a fairly large study in Montreal. And they all kind of give hints that there's something to be worried about, but there's no, as Jan said, they're all different, and there's no real one thing you might expect for exposures living around a landfill. Each landfill has its own mix of waste and leachates and things that might, people might be exposed to. It's hard to make a generalization like that.
Thank you.
That answer your question? Do you feel
It
that
does.
that's what you feel? Great. Thank you.
My sidekick here, Madeline Scammell, just reminded me that there are also diagnoses other than cancer that have been looked at around landfills, including asthma. So it's good that there was information about the Finn School here, and needs to keep being gathered.
City Councilor Mary Ann LaBarge from Ward 6. I want to thank the Mass Board of Health for being here this evening, and also Gradient and the Board of Public Works for putting on this meeting tonight. The only problem I have is that we had a huge meeting at Ryan Road School in 2006 and 7 in regards to the problems that were occurring around the perimeter of the landfill with an increase of cancer. I'm talking about 2006, 2007. This report on gradients has only gone to 2004. I would like an answer of why we have no recordings on 5, 6, or 7 or up to the present, especially when the increase was crying out then to our mayor at that meeting at Ryan Road School and me as a counselor. I'd like to know why that there was no studying done from 5, 6, and 7 and up to present. Thank you.
Thank you. So I think that can be answered separately by the two different authors of your studies.
I could start by saying, the landfill has been around for a long time. And if the landfill were associated with increased cancer, you should have seen it. It wouldn't have just started in 2006. You would have seen it before that, and it would have been counted in your study. That being said, it would still be very important to look at that time period, but that data was not publicly available. I mean, Jan can talk about the issues with that, but the state did have some of that data, so Jan was able to look at it.
You know, I did present a lot of information, but for the 1 mile radius around the landfill, we did review data up until the present, which really meant up until a couple of months ago, because that's when we started compiling all the report itself. So we do have access to diagnoses in 05, 06, 07. It's very unlikely, well, we didn't see any reported for 08, but we did look at data for those later years, just for the 1 mile radius. And the reason is that in order for us to calculate statistics, we have to wait till the whole statewide database is complete for a given year. And it's always a few years behind, and that's because there's a lag in reporting by doctors, and then there's a lot of quality assurance, quality control work that goes in, to eliminate multiple reports of the same cancer, because a person might go to a hospital, then to a radiation facility for treatment. So we don't have complete statewide data for those later years, but we did, for that 1 mile radius, take a very close look at every single person reported to the registry from 1989 until a couple of months ago.
Okay. My main concern is that Gradient was hired by the city to go ahead and do the testing. I'm still uncomfortable that we do not have anything from Gradient from 2005, 6, 7, and right up to the present.
Well,
that's my concerns.
Well, Gradient would not be able to get that from the state. We have the statistics. There are lots of very strict rules on releasing these cancer incidence data, and when Gradient accessed or requested the data from the cancer registry, at that point in time, the last year available for which they could actually calculate a cancer rate was 2004.
So I think my main concern would be, at a meeting, when Gradient came, I think they should have specifically stated to the public that you would only be going up to the year 2004, when the outcry came in 2006 and 7 of an increase. That's my concerns.
We did mention that. I believe you have the slides from the last time I spoke to the city saying I was going to 2004, but I do want to reiterate, what our goal was to see is if the landfill led to increased cancer risk. That's really what the concern is.
I think I'm hearing that there is a concern about recent incidents from 2005 to the present, and I've recorded that. I think what we're hearing is that we can't answer that with the data we have available now.
Thank you.
But it's a concern. Thank you.
That's not true.
No, I do want to clarify that I feel like the data are not complete for these most current years, particularly 2008, but we did review up to the minute reports for the 1 mile radius. So I want you to know that we did look closely at that particular area.
Okay,
We didn't-
I misspoke. I didn't mean to say that none of those data had been addressed. I meant to say that the complete analysis that was able to be done in 2004 can't yet be done for the recent years, and there is some desire to see that done when the data are available. But thank you for correcting me that some of those data have been looked at in that way. I appreciate the corrections. There's so much technical information here. Come to the mic, please state your name, your question.
My name is Amy Feinler, and I live in Leeds. And I guess this is just a general research question. When we talk about risk factors, I guess I would like you to comment on how that relates to cause and effect, because as I heard you speaking, where I got confused was, and I would not like the implication to be made that where there are risk factors involved, that therefore negates the possibility of some kind of detrimental effect of the landfill. And it's really a question. I mean, I don't know how risk factors are taken account for in that, and how you know where the cause is coming from given the risk factors. Does that make sense?
I think so. I'll try. The reason we look at the risk factor information, it's one more piece of information. But for example, I mentioned this is an example for brain and central nervous system cancers. We know that there's greater incidence up to age 10. Then we know there's a low, and then there's a greater incidence from 25 on. When we looked at the data for Easthampton, the age pattern for the Easthampton individuals was just like we'd expect. So that was reassuring to us. I mean, there are certain cancer types where if we saw even 3 individuals diagnosed at, say, age 20 for a particular type of cancer, like kidney cancer, which is more commonly diagnosed in your 50s, that would be a red flag to us. And we would we keep that in mind. We possibly recommend follow-up for that. But so it's just one more piece of information. It doesn't rule, it doesn't in and of itself rule anything out, but it helps us sort through the data.
I guess that's the point I wanted to make, is that I hope that we're not ruling things out.
Right.
Just due to that.
We aren't, and
there are
that's...
still remaining questions in that.
And that an example of how we don't allow smoking, for example, to rule out, and we look at the pattern among non-smokers. Are we missing something? Are we saying, well, that's elevated, but it's due to high smoking rates? Well, the way for us to try to get beyond that is to look at the pattern among the non-smoking population. So it's how we piece it all together. It's just not a straightforward approach.
Thank you.
Hi, thank you for your clear presentations. My name is Bridget Holt, and I live
Close to the
on
mic.
Glendale Road. Sorry, I live on Glendale Road, and so my backyard shares a fence with the landfill, so I am within the 1 mile of your track. The question I have is there a way with the cancer registry data that you can evaluate the independence of the cases reported? In other words, you have breast cancers, bladder cancer. Do we know whether any of these were the same individual with multiple of these cancers?
We would know that because we have access to we have access to name, address, age, so we do know that.
And there were none of those found. Those were all basically
Individuals.
separate individual cases.
I don't feel like we can answer that right now. We have to look back at the data. But we can do that.
But people do get more than one cancer in their lifetime sometimes, so it is possible that people could be double counted even though it's the same individual because we got 2 different cancers. But that's taken into account in how the SIR is calculated.
No, I guess I was more concerned with the idea that would it be a marker of the profile of a landfill issue if you had an abnormal number of individuals showing up with multiple.
It's most
not so much how you ended up with the counts, that I'm not worried.
I don't think necessarily there's really any information in the literature that would say multiple cancers are associated with landfill exposures. I'm not aware of anything like that.
I'm not either.
My name's Bob Harrison. I live 1.2 miles from the landfill, so I'm in kind of that discomfort zone. I'm not sure what to characterize it as. I think I've heard pretty much.
Can you smell it, Bob?
I'm hearing like two sides to, or some clarification and then some muddying of the statistical model. And there's a degree of certainty or probability that says that it's probably not an effect in its statistical model. And then in the reality of when you wipe away the tears of the statistical model, there's still a tremendous amount of suffering. So that the false negative that it might portray is very serious, and I know everyone appreciates that. And so there's a degree of probability to the studies up to 2005, I guess it was, or 2004. Does that get the latest contemporaneous data that you have that hasn't been fully studied yet? In that, there's a degree of uncertainty in that there's a whole constellation of new chemicals that weren't being contributed to the existing landfill for that history from 1969 up until whenever those chemicals were introduced into the landfill in concentrations and constituents and synergies that we don't understand yet, or their effect on human health. I know that some of these things are listed in federal registries for potentially toxic things, but there's also GMOs and pharmaceuticals that are at play here now that weren't of concern in 1969, that didn't exist in 1969, that didn't exist 4 years ago, 2 years ago, or even a year ago. So there's a degree of uncertainty into any of these statistical models, and that latency period that you talked about, there's a degree of uncertainty that is still going to be present as we move forward into the future, which will always have emerging threats. So what I'm going to ask is, and I know this is unfair, is there any predictive software for this kind of study? And how does it interface with the environmental modeling for air pollution and water pollution that the city does? So they make all these models. They've gathered all this data. And has anyone evaluated in its totality in a scientific manner? In other words, and you have topographical maps. I know you had that map, the center one I didn't quite understand. I guess it was the demographic centers of...
The middle map?
Yeah.
So that
That's why you showed the population, you showed the tracks, but the distribution of population, even in something which might seem insignificant as topography. But my experience with the landfill is I sometimes go over to play cards in Easthampton, and I go down Clark Lane. And I know it's 100-foot, roughly about 100-foot drop in elevation from the landfill that's sitting 100 feet above it that has fugitive emissions, and they move to control them and try and get it under control. But at present, it's basically a cauldron that's boiling. And so when the meteorological conditions are right, these things are going to flow downhill, just like a fluid behaves. And it's going to go down into Clark Lane, and I smell it. And it's going to go into an area where they're building homes. And it may go into a demographically charged area where there's more people, density. So you distribute that statistical model out through the borders of the census tract, and it may appear differently than like Dr. Clapp said, that you might have to look a little closer to see how it's
summarize
distributed.
what I think I'm hearing as
Absolutely.
a concern and a question? I hear an echoed concern about recent incidences, perhaps that they reflect recent chemicals in the landfill, and that looking forward and continuing to monitor health into the future might help us get a better handle on some of the more recent potential contaminants in the landfill. Is that correct?
Yeah. The known
Glad
ignorance.
that that's been mentioned.
The known
The
ignorance.
recent data matters to people. And then I think I understand your second question to be, is it possible that trying to normalize by population density doesn't completely erase evidence of a cluster, because there could be a particularly dense population of people that are exposed to a contaminant because of their location, just happens to be
Proximity to
dense.
the contaminant.
So is that that's your
Yeah.
second question?
Yeah.
Is there someone
And
else?
their exposure.
Actually, I mean, I think one of the great things about having these two separate analyses is when I looked at my clusters, I did it, looking at whether or not it had to do with denser populations, where I believe what the state did was actually exactly what you're saying. The first level of it, right, was just looking at distance from the landfill, right?
That was the closest level, that 1 mile radius. You know, this,
Well, then there's the unknown ignorance, right? I think you're asking about that too. Can we predict what's going to happen from these more recent exposures on people who are going to be there in the future? And I think the only answer is no. We don't have those tools. There's no statistical model for that, or there's no software for that.
I wouldn't entirely disagree that there's nothing we can do to predict the future. I mean, obviously, if there are compounds that we don't know that they will be put into the landfill in the future and we don't know their properties, it's possible to not know something clearly. But for things that are recently done there, if we know something about their toxicological properties, you can measure the amounts of exposures that happen. You can actually do mathematical models that look at the tumbling down of the vapors over the hillside that you were describing, and see how great that would be and find out what exposures people would be expected to have to these. If we know something about the toxicological properties, and if we can measure or model the exposures that people would have, there is something to be done. Now, that's not the topic of this meeting. That was not the topic of our analysis, which was to see what we see as having happened in the past. But in principle, those things can be done, and my understanding is that a lot of that kind of work actually has been done. But I'm not the one to speak to that.
Thank you for your question.
I am Nancy Nelson from Easthampton, and the gentleman before me did a much better job of asking my question, but I'll try to say mine. I mean, basically, I appreciate all the work that's been done on these studies, but I really appreciated Dr. Clapp's comment that, you know, it's not conclusive, and I go further to say that the unknowns are huge in this situation. We don't know what will happen in the future based on what you guys have studied, and I do feel like animals instinctively know not to foul their nests, and so it should be basic common sense. This is more for the city, I think. It's basic common sense that we shouldn't dump waste on our water supply. If you want a question about the studies, basically my question is, there are so many variables and unknowns. You took data on people who are living there now. We don't know how long they've lived there. We don't know who moved. And then, as this gentleman's bringing up, they're building new houses. So, you know, we're putting more people at risk. You know, I have a clear opinion about this, but if you want to speak to that.
I think it's true that there is unknowns, we can't know everything, but Massachusetts does have, I'd say, one of the best cancer registries in the country. So I think that these studies really did, yeah, you can never be 100% sure of anything. You can't be 100% sure when you cross the street, you won't get hit by a car. But I think that these studies really did a lot to address these questions.
you know, I guess I also, I hope I made it clear, you know, we're doing the best we can with the data that we have. Based on the close examination that we did, we didn't see anything, any commonalities that we were concerned about. But again, you know, we did look at many years' worth of data. It's not perfect because people do move away. People do move into neighborhoods too. So there are clear limitations to the data. I can't deny that, and I hope I didn't want to present it in a different way than that. But from all of the information we looked at, it was reassuring to us that what we learned by looking at all of that. And you know, I hope I made it clear too, we never just look at the statistics. I mean, we pore over the maps that we have. We did that for that 1 mile radius. We didn't see people with particular types of cancer that were grouped together. You know, we did look as far as we could look out into the database in terms of looking at the most recent diagnoses that have been reported to the registry. We did, in our report, we committed to continue to monitor the cancer incidence for the communities, and we will work with your local health departments. They get a report from the Cancer Registry every year that gives them, it's a report of 5 years of cancer incidence data, and it's updated every year, and we are very willing to help them take a look at those data, drill down to the census tract level again. So we will keep monitoring it. But, you know, I recognize fully the limitations.
Hi, my name is Linda Ziegler, and I live right near the landfill. I can tell you it's a living hell. Anyone who wants to see Gradient's Table 48 that Dr. Clark referenced, that wasn't on the screen, it's on the walls around here, on the posters. I have a question for Jan and Dick and Madeline, and I want to make sure I understood everything correctly. But before we go into that, I want to mention that, Jan, you mentioned the high sodium levels. That was my home well, okay? And there was conjecture that it may have been road salt, but Dr. Newton came to my house and studied that water this summer, and he concluded that it was from leachate and that the sodium was of a carbonate type, which is the exact opposite of road salt. So the sodium in my home well is from leachate migrating from the landfill, okay? And you also talked about some home wells being near the upper limits of contamination, which was my home well, which was the arsenic, and I got your letter where you added all 3 tests and divided by 3 and determined just because it was slightly under 10 that it was all right, that the arsenic level was all right, but the EPA standard on the website says the aim is to be at least 3 or to have no arsenic whatsoever. So, yeah, there are limitations to studying data, and you got my email where I said I was very disappointed with that conclusion. It didn't seem like a logical way to determine whether there was a problem. Be it as it may, and also I want to know, when you studied the new houses, when you studied the area within the landfill, there are new blocks there that didn't exist before. So I'm afraid the data may be skewed. Pine Hill Road never used to exist before. It used to be woods. There are homes on Clark Lane that used to be all farmland. They were never there before. So I don't know if that's taken into consideration, but I just want to make sure I understand what you presented. You said Northampton, or it was presented that Northampton as a whole has a lower cancer rate compared to the state of Massachusetts. However, the census tract where the landfill is in Northampton has a higher kidney, breast, and bladder cancer. Also, you've talked about breast cancer being associated with higher socioeconomic levels or higher education. So we all know that it's no mistake the landfill is where it is. It's a lower socioeconomic level over there, okay, and they have a higher breast cancer rate. Kidney cancer is elevated in the census tract near the landfill in Easthampton and in Northampton where the landfill is. So I'm wondering what the correlation is, because there's a multiplying effect. Asthma is associated with.
And Linda, I think I'm losing a little bit. I wasn't trying to cut you off. I'm just saying I'm losing a little bit of track of the questions. So I'm expecting that.
I'm trying to show that there are various cancers that are over the state average.
Okay, so that
okay,
have been
in the area of the landfill, and I'm building up for Jan.
Okay.
Asthma is higher in the area of the landfill in the census tract. I want to know, is there a correlation with all those, but more specifically, can you go back and get back to us about multiple myeloma? I'm not pronouncing right, myeloma is an uncommon cancer, and it's more common in men, yet it's high, or in the vicinity of the landfill for females, and that's a great concern. And also I want to know if for the non-Hodgkin's lymphoma in the vicinity of the landfill, did you look up to the present date? Because we all know that there have been other cases since 2004. That's my whole question.
I think we're all going to need help making sure we got them all. So,
well, Jan can ask me as she goes.
Okay, and if we didn't get to something, you'll tell us.
You brought up a lot of issues, and I feel like I did address a fair number of those in my presentation. What I'd like you to do is to go home and look at that report and look at all of the data. I went through it as systematically as I could. I don't feel like I can, you brought up so much, I'm honestly not sure how to respond to all of those points. You know, I did look actually at multiple myeloma recently, and that was because I knew that Dick had taken a look at it, so I looked at a map, and I can tell you that we did not feel that there were any clusters of individuals. I would be happy, though, to look at the statistics over time, which I haven't done. But in terms of all of the other cancer types, you know, I pointed out where there were elevations, and I did not deny that. But what I did is I looked at the complete picture. I looked at the 23 years of data for the census tracts in the communities. We looked closely around the landfill itself, and there were elevations at times, but it was my job to try to synthesize all that information and interpret it as best I could. I did it in a way that's consistent with how we do it across the state. So, Linda, I'm not sure what else to say. I mean, I'd like you to look at the report closely, and if you'd like to send me a letter with your comments, I'd be happy to look at them. But you brought up, I don't know, 8 or 10 different points, and I'm not sure, honestly, if I can respond to them all. I feel like I addressed a fair number of them tonight, but I would be happy to respond to your comments if you want to. You know, you can take a look at that report closely. And I have no vested interest in this. I went into this field because I care about people's health and I care about the environment. I felt that we did a really thorough job, but there's always criticisms, there's always limitations, and I'm happy to talk with you about those.
It's not a criticism, it's just that there were elevations and there were some commonalities in the elevations. To tell you the truth, we weren't looking for a cancer cluster, we wanted to know if there were cancer cases in the vicinity of the landfill that were above average, and that Northampton itself as a whole is below average, and the vicinity of the landfill is above average in several different types of cancers is of great concern.
Well, I do want to point out that we never evaluate cancer as a whole. I know someone reported statistics for that, all cancers combined. There may be some usefulness for that when you're thinking about access to medical care or screening rates for cancer, but if we want to look at what might be behind an elevation in a cancer, we would be hiding all sorts of things by looking at total cancers. That's not very informative for us at all.
The gradient report gave the total cancer rate for Northampton. Thank you.
Okay.
Thank you, Linda. I did hear one other point that I just wanted to, that I think I did pull out of what you said, which is that that in some of the analysis, it might make sense to continue to look at socioeconomic levels around the landfill if that weighs in as a risk factor or a counter risk factor, that to keep that in mind, if it's true, if that can be evaluated through census data, that could be something that could be looked at in the future through analysis.
I guess one point that I do want to make about breast cancer in the census tract around the landfill in Northampton, I think it was very telling that we learned that there was quite a difference in the percentage of women diagnosed with the earliest stage breast cancer that can be diagnosed, the in situ diagnoses. And around the landfill, I think it was 40-something% compared to a statewide rate of 24%. That's quite a significant difference, and I think it's telling, and it's what it means is that women in Northampton and in that census tract are getting screened early, and they're getting screened regularly, and they're getting diagnosed very early, which is a great thing. So I think that should be reassuring to people.
It's okay, they don't hear you.
But we won't.
Jesus Leva, 33 Maple Street. And I actually had a couple questions, which I'm going to try to phrase as best as I can. The first one is the state study said something about the asthma prevalence being high, but that you attributed that to it being reported more often. Is it possible that
Well, I talked as I mentioned, to the nurses who are closest to the situation. What I do want to point out, at the Finn School anyways, for the first 3 years of data that we have, the rates were as expected. It is that last year where it was elevated. And that's the reason why I talked to the nurses, to see if there was something going on. So, we're going to have another year's worth of asthma data soon that we can look at. But I think the nurses, they're the ones closest to the situation. And I think it's very good information that they provided. A lot of times when you look at disease rates, they can change, and sometimes it is due to changes in reporting. And they felt that because they improved their reporting forms for reporting health conditions and medications that the kids take recently, that resulted in parents being much more diligent about their reporting. So they didn't really see it as a spike. They really didn't. They thought it was a function of better reporting, and I feel like they know better than I do.
Okay. I was wondering if, I guess this is for both the grading people and the people from the state, if there was any response to what Dr. Clapp had brought up about, I can't think of the exact names of the diseases, but he had mentioned there being a difference of 4 cases in Northampton, and the difference between 2 statewide, and then, or not statewide, but like that's the ratio, and then the other one of point, right, 0.8, and the other one being of 3. And I'm wondering, I know it's been explained as possibly because of there's just such a small, that's such a small number that it's really hard to draw a conclusion from that, but I was wondering if you had anything to say about that.
Well, there were a number of instances, and when you look at the report, there were instances where there were differences of 2 or 3 diagnoses. And I mentioned early on, when we did look at the cancer types that we focused on, if there was a difference of more than 1 or 2 diagnoses, we did look at maps. We did look at the characteristics of the people that were diagnosed with those cancers to see if, for example, they were much younger when they were diagnosed than we would expect them to be for that cancer type. So, I guess there was one point made, I think that you had talked about not calculating, how we don't calculate a statistic when there are under 5 individuals diagnosed. We don't calculate the SIR, but we do calculate an expected number. So I feel like I don't rely just on those SIRs, and I don't think that tells the whole story. So we looked closely when there were differences of 2 or 3 diagnoses. And to be honest, if you look at data across the state, it's not at all unusual to see those kinds of differences. And that doesn't make me not look carefully at the data. We do every situation that we look at, we pore over the data, even when there are those small differences, and even when we see them statewide. I don't think there's one community in Massachusetts that you could look at the statistics and you wouldn't find some differences from what you'd expect. It's just the nature of, they just vary naturally. But what I want you to know is that we still look closely, even when there are small differences, to the best that we can. It's not perfect. It's easy to poke holes in this kind of thing, but I want the community to know that we take it all very seriously and do the best that we can to look for something unusual. Because we don't want, we're in public health because we care about the communities here.
Yeah, that's good to know. And then I guess the last one is actually something that I guess a lot of people have already spoken to or have asked about, but I guess I want to maybe phrase it a little more clearly or add something else to it, which is there's been some mention about the data only going up to 2004 and of the fact that is it possible that within the next couple of years that there might be data that would show significantly higher rates organized, the operation was different. And so I'm wondering if there's a possibility. Well, I guess my real question comes down to, we're going to have the Board of Public Works and then the City Council voting to expand the landfill. And what I'm asking is that should the groups of people who are going to be voting on expanding it take comfort in this health study as being, as that there are no health issues relating to the landfill, or that we don't have the data that's necessary to determine that, and that we should still consider the landfill a possible health risk?
Thank you.
You know, I guess we've alluded to this a little bit. You know, I think there's comfort in the fact that we've looked at 24 years of data so far. But I can't say to you that, you know, in another 3 or 4 years, when we look at more data, that we aren't going to see elevations. All I can tell you is that we've looked at a large chunk of information, a large chunk of data, and that based on that, we didn't see patterns that concerned us. You know, there are all sorts of issues related to this landfill that are, you know, there's monitoring data that the city routinely collects to look at. You know, it's not just, I don't think any decision should be based just on the health data. I think there are issues that I have no appreciation for related to this landfill.
Well, I'm not asking them specifically to.
I'm concerned about the number of people that want to ask other questions.
Right.
If you do feel like you've gotten most of what you need, I'll let people get a chance to ask. What I will say is that I'm hearing from you an echo of concerns that have been raised by previous speakers, and I will be summarizing some of the themes I hear. And one of the very loud themes I'm hearing from you and other people is there's concern whether there's sufficient caution being used by the city in interpreting these results. Is that accurate?
That's fine, thanks.
Okay, thanks for your patience, and I appreciate you willing to share.
Hi, thank you so much for being here tonight. Appreciate it. I'm J.P. Kwasinski, Easthampton City Councilor, and I live within 1 mile of landfill. And have for the last 15 years. I'd like to start first with the gradient folks. I know you had said that your study was a study of the landfill versus the background of the state, and the landfill in Northampton versus the background of the state. And you mentioned very quickly that there may be similar cities to Northampton, but you chose not to look at similar cities. And I guess the state didn't look at similar cities or similar circumstances, socioeconomic status, et cetera, et cetera. What would be some of the similar cities that you would mention? Do you remember mentioning?
No, I do, and I think the reason why I said that is I was just really trying to differentiate this kind of study. There are many types of epidemiology studies that are conducted, and in some of these studies, you actually compare sort of two groups of people. So, you know, I guess for example, you could compare people in a city that has a landfill with a city that doesn't have a landfill, and look at those statistics. The strength of this study is having this statewide data. And Jan talked a lot about, with using numbers from the state, you have more numbers of people, so you have, in statistical terms, you have more power. But the idea is you have a bigger ability to really see if there's something happening because you have these bigger numbers to work with. So that's why we compared it to the state instead of other cities. It's because it gave us a greater opportunity to see if there really was something going on because we had bigger numbers to work with.
Could I just say something in terms of like doing like comparing Northampton's health statistics to another community? You know, it just raises all sorts of other issues because it's very hard to account for all of the differences between two communities. You know, the age is actually one of the easier things to account for, but you know, there's so many variables that affect disease rates. You know, just thinking about, you know, you might have your concern is a landfill here, but in another city, maybe of similar size, there are other environmental issues that are of concern. You know, there might be a local industry that's polluting the neighborhood. You know, it's a very difficult thing to do, to compare without, you can really poke holes easily when you do those kinds of comparisons. And you know, when we do these things across the state, there is the advantage with the statewide data that we do have more stable numbers, and it's, you know, it's a huge population that we're using for comparison, and it gets rid of some of those other issues that arise.
Did you have another question?
A few more.
Okay, we've got a few people behind you and very little time left, so I'm going to ask you to crystallize your questions to the most important and in a very short period of time.
I've had about 10 minutes to look over your report, and we had to go outside to grab. And so I haven't had a chance to digest it, but I'd like to follow up on Councilor Labarge's question, which was, I think she had said that there were several instances of cancer that she was relating to in 2005, 2006, 2007, and that she was concerned that these weren't studied and were examined. And I know I heard you say that you would look very closely at the data, and you would study the situation. Could you tell me where in the report?
Yeah, there's a section in there.
06, 07, and 08 data, the raw data of observed cancers are?
Well, it's the section that we call, in the results section, it's 1 mile radius. 1 mile radius surrounding the landfill.
Okay.
Oh, when we looked at that 1 mile radius, we did not calculate rates. So you're not going to see those numbers in here. What you're going to see is a 2 or 3 page discussion of the types of cancer that we saw, the patterns that we looked for, and that sort of thing. And that did cover.
My question is, did you put in raw data into the report?
We didn't put.
The number of instances.
I put things like there were 113 individuals, there were 24 different types of cancer.
In the last, 05, 06, 07.
Oh, no, I did not break it out just by those years.
Will you be putting that in an addendum to the report at some point?
Well, you know what
To share that with the public?
I mentioned we did say that we would continue to monitor cancer incidence data. Right now, you know, in another roughly a year, we'll have another year's worth of data, and at that point we can see. You know, when we have enough complete statewide data, we will do rates. I'm not being clear about. Issues of privacy? Well, that is part of the reason why in that particular part of the report, we don't say one individual age 52 had this type of cancer, and that is dictated by privacy concerns. So you'll see a discussion, but it's a summary discussion, and we don't give detailed information for privacy reasons.
Yeah, okay, thank you. So we're going to let other people ask questions, and again, there's going to be resources in the form of contacting the researchers individually to follow. All right, he's not interested in my answer, so you go ahead.
Hi, I'm Lillian Fedora, and I live at 238 Glendale Road, and I actually bordered the landfill for the last 30 years. My question is, I know that we have the Massachusetts Cancer Registry, but that is only really anything that's been reported, correct me if I'm wrong, for people that are in Massachusetts. It doesn't deal with anyone that lived there for a while and then moved away. Is that correct?
If they moved away before they were diagnosed, that is correct.
So you could have a number of people that lived in the area, not just with cancers, but if we're talking, say, asthmas, migraine headaches, I mean, it could be all different kinds of conditions where people lived in that area within a 1 mile radius, moved away, and never have been detected whatsoever.
That's right. That is the limitation of the registry. It's true for most registries in the country. And like I said earlier, there are going to be people, though, who do move into the area and are going to be in our cancer counts, but maybe lived in Northampton for a month. So, you know, it works both ways, I guess is my point.
Right. Well, what I'm also trying to get if we're looking to see if there really is a health concern within that 1 mile radius, and I know there are the privacy issues on this, I can't see why, if there was a letter or a postcard, something that got mailed out to people within a 1 mile radius, and you're kind of looking for health things, it doesn't have to be maybe cancer, maybe it's migraines, maybe it's this, and if they decided to send it back in, it would actually help to update the cancer register if people had cancer and just haven't gone to be diagnosed or whatever yet, or other conditions that are happening.
It sounds like you're talking about sort of like a neighborhood survey.
You could do 1 mile, 2 mile, I mean, just get a survey. Are there things happening, and would that help?
Well, you know, we get asked this question all the time when we go to these meetings, and we generally don't suggest doing neighborhood surveys, and there are a couple of reasons. One is that the kind of people who are going to respond to that survey are they're individuals who do have concerns, legitimate concerns. But it's very hard to interpret the information because unless you have a comparison population, I wouldn't know whether that's an unusual number of migraines or not. So that's one of the problems. Another problem is that, you know, when we do our evaluations, there's an issue with whether people are reporting accurately. I mean, I can't tell you how many times I've been on phone calls with people and they'll tell me a particular piece of information about their diagnosis, and then when I go to the cancer registry, it's not what the physician reported. And, you know, it varies depending on the kinds of conditions that we're talking about and everything, but we tend, especially for cancer, we want to have doctor-reported diagnoses. So if we're looking at subtypes, for example, we know that it's an accurate report. And so that's one of the things.
Then I have just one other thing, Jan. I was just wondering, in your opinion, do you think it is a healthy environment to be living near a landfill?
I honestly, I don't know if I don't feel like I should answer that. It really depends on the conditions there. I mean, some landfills, I mean, we have waste, we have to deposit. You know, it's an industrial society we're living in. We have to put it somewhere. I think there can be very well-run landfills. I think there can be landfills that aren't well-run, that may very well pose a risk to people. It's just, it's not that simple. And as a scientist, I don't feel like I can just simply say yes or no to that.
Because it's a little bit after 10, I'm going to let you ask your questions. But because I know people are starting to trickle out, what I thought I'd do is just take 2 minutes to summarize some of the themes that we have heard so people who are leaving may be able to hear the themes that have been caught. And then I'll have you ask your final 2 questions. Is there anyone who hasn't stood up just because they're tired but they were planning to ask a question? Okay, well, I appreciate your patience. I think we can make it through the last 2 questions then. But in advance of that, I guess I'll just take a couple minutes to summarize some things. I said one of them already. There seems to be great concern that these studies continue into the future and take account of recent years of data, and that we don't lose sight of anything that's happened in the recent years. There may be much more we can do with those data as time plays out. So people are very concerned that those studies continue. There also has been a couple of people who want to make sure that just because there may be other explanatory factors, we don't rule out that the landfill also may be a contributing cause, and that if we can explain it via other factors, not to assume, therefore, that there's no effect from the landfill. I've heard that from a couple people. And then a theme from almost everyone who's spoken that these are issues that decisions should be made with a great deal of caution around these issues, and that there's different levels of confidence in the studies that have already been done, but that regardless, whether you're confident in these studies or not, that decisions around the landfill should be treated with a great deal of caution. Those are themes that I have heard so far.
Hi, Pat Wetzel, Mountain Street.
Microphone?
I don't know whether there's really an answer you're going to give me on this, but I'm puzzled because it appears as though, on the one hand,
cancer types that were, the incidence was about as expected. There were a number of cancer types that were elevated in one time period perhaps, some of them over a couple of time periods, like brain cancer in Easthampton. But the way we evaluate these is to take a look at all of that information in relation to what we would expect, based on either the statewide experience for these cancer types, or based on what we know from the medical literature. And that's the way we can do these kinds of investigations with the information that we have.
But you say they are elevated in that area, but you're also saying...
in the census tract, which for both Northampton and Easthampton, those are very large census tracts. They cover a large geographic area. So when I say elevated, I'm saying for the census tract as a whole. When we did look closer to the landfill in that 1 mile radius in a qualitative way, because we didn't have data so that we could do rates, we did not see unusual patterns, taking all of the information we had into account. But, the reason, what's hard with census tracts, especially in places like Northampton and Easthampton, is they cover a very large area because it's a more rural community. Census tracts typically are 1,500 to 8,000 people. We knew that it would not really address your question if we just looked at the census tracts in the communities as a whole. And that's why we tried to take a closer look around the landfill. But I do want to say, within the census tracts, we looked closely at the maps to see if there was anything going on in certain neighborhoods. Not just around the landfill, throughout the census tract. We did that for all of the cancer types that we looked at.
And finally, this is more of a comment than a question. I'd like to say that the landfill is not one entity that has remained this way since 1969. Remember, it went from a Northampton to a regional. It had at one point ink waste that were added in, then oil and hospital waste, et cetera, et cetera. At various points in time, other things have been added. So when you think about the latency period for cancers, you must also be thinking about the fact that this landfill has had different VOCs in it over time.
Hello. Not a bit too close. My name is Pamela Grant. I live on Sylvester Road. And I've got a couple of things, but pretty quick. Multiple cancers. If multiple cancers do occur in an individual, and it happens in a large number of individuals, then that would be a red flag?
It's a good question. It's not unusual for an individual diagnosed with one primary cancer to be diagnosed with another.
Yeah, I do understand that. But if you had multiple cancers occurring in multiple people within an area,
I guess it would really depend on
what else was going on in the area?
Well, what we would look at is the mix of cancer types, and we look at all of the same things that I've talked about
The
tonight.
industrial base, what's going on?
Yeah, in the age of diagnosis and the dates of diagnosis, we look at patterns.
I just wanted to point out that there was one more person who came up behind you with a question.
Okay, all right.
Be as brief as you can.
And one question, Jesus answered a question that I had, which was, when did the landfill become regional? And if that was indeed in 1990, I would point out with the 10 to 40 year latency period for cancer to develop, that we're only 18 years into that potential period. So those things are only just beginning to show up, and that a study of this kind, as you've noted more than once, people are indicating this needs to go on. It's not yet. Al Gore recently received, or not so recently received, the Nobel Prize for the hole in the ozone layer. When I was 12 years old, we started telling people that CFCs and other things that were going to damage the ozone layer needed to be stopped then. And the retort was, well, you have no conclusive proof. And the scientists came back with
by the time you have conclusive proof, it's going to be too far gone to be able to reverse the effect. So we're all going to be looking to be living underground in a number of years. And so you can't just keep dumping stuff, and I agree, you can't build over an aquifer. One thing I really would like to understand,
I'm really gonna have to ask
confidence interval. This is very important because it's all about the statistics. You're overwhelming these people. Although I did not complete my degree, I started as a chemistry, changed into a biochem/microbiome major with a minor in chemistry. So when you talk about statistical stuff, it means something to me. It's been a lot of years. I don't really understand it all anymore. The confidence interval, you guys keep returning back to that as some kind of an indicator. And then there's the percentage point. You know, it's 95% or something. And then there's the confidence interval. That the interval is something like 200. So I don't know if you can talk to that a little bit, or maybe do an addendum to your study so that people are better able to understand what those numbers mean. Because when you say 40%, this number 40 with the breast cancer, and that should be encouraging, I can follow that logic around those bends. I'm not so sure that other people can follow that kind of logic.
Well, our report does have a section.
I thought it was more public at student.
It is. We have run over the public comment period, and I appreciate you finishing up your comments.
Our report does have an explanation of those statistics, so I hope it'll do the trick. Because we try to make it understandable to the
And
layperson.
I want to encourage people to follow up individually with the researchers as well with specific questions. And can I ask you to be just
I will try to be very
30
brief.
seconds.
30 seconds. My name is Kathleen Hughes, and my daughter just moved into the area, and I'm a math teacher, and I know, have reference to books of how you can lie with statistics, not intentionally necessary, but you can word things and collect samples that you can tell anybody what you want to tell them. I'm not saying that's happened here, but I would be suspect with this. And as to compare it to the rest of, the state, things perhaps are rising in the state in ways we don't want to have it happen. I would be more apt to rely on people like Dr. Knapp and others who will tell us more, they are looking at the data, not because they're looking at large samples. When you measure statistically, if you have large samples of people who moved into the area and you're not counting the people who were here years ago, so they definitely would affect your sample. So you have to look at all those things when you talk about this.
Can you wrap it up?
Wrapping it up, I would say that I also have a question on whether or not this is a source of revenue for the towns of Northampton and Easthampton, and is that a way in which people are looking to increase the size of the dump for reasons of revenue? And that's a good question.
Good question.
Thank you. And I am
Thank you for
sorry
your
to not
time,
be able
and
to
everybody
let you
did
speak
very
as
nice
long
job.
as you want. I'm very concerned about people being able to get to bed tonight, but I appreciate your comments. There was a question there at the end, and I guess I'm going to ask if the board would like to answer that question, which is, does the town generate revenue from the landfill? And is there a relationship between that and any other decisions?
Once again, I'm sorry, that is a good question, and one that we need a public discussion on, but not at this meeting, not yet. So we're going to talk about options and the bigger picture of what happens if we close the landfill versus keeping it open, and this will bring up this question at our next public forum. So I hate to punt on that, but it's getting pretty late.
No, I understand, and I want to remind people that there will be a few other places where these conversations can continue. One of them will be the public forum that the city's going to set up around looking at options for how to handle the waste and decisions about the landfills. And I think many of these discussions may come up again, and that can be a place for them to play out. Another resource for people who have questions is to contact the researchers, follow up individually. I don't want to speak for all of them, but I have heard Jan say that she's accessible that way. Sounds like there's nodding consensus there. And I appreciate that everyone has been incredibly patient around issues that matter very, very much to them. We've heard some scientific consensus, some potential disagreement, a lot of concern and a lot of emotions around some of these, but people have been respectful. I believe that we've captured a lot of the themes. There have been some repetition of themes, so I really, really appreciate the respect people have brought to this meeting, the thoughtfulness that you brought to your questions, and I hope that you figure out ways to continue to have productive conversation around this in the public forums that are to come, and in all the other creative ways you can figure out to talk to each other about this. So I'm going to officially end the public comment period of this meeting, and we're going to turn it over. If you would like to waive the 10-minute break and move right into board meeting, I'll leave that up to you.
Excuse me, where do we go to contact people, or is there a list, and so there's a study outside or something?
There are boxes of the DPH study outside, and can everybody contact you at the city to get contact information for the researchers?
Yes, you can pose a question to the DPW, or if anyone would like to me, and if you've got a pen and pencil, my email address is reckow, R-E-C-K-H-O-W,
Can you do that again? It's kind of hard.
R-E-C-K-H-O-W @ecs.umass.edu.
And what's your name?
Dave Reckow.
And thank you to the board for having given so much of your meeting over to public comment here. And I appreciate your patience, because now you have questions.
And thank you. And thanks very much, Sarah, for what you did. What Sarah said, this closes the public comment portion of the meeting. You're very welcome to stay. What we'll do is we'll continue with questions by the board of our experts here. I also want to thank them, commend them for remarkable endurance in lasting through this very long meeting.
I want to echo that. The responses to questions, the attention to detail, the presentations were tremendous information, and you did a fabulous, fabulous job handling a lot of information, responding to a lot of concerns. Thank you very much.
So, if we could, questions from the board. But before we jump into these questions, I just want to say one more word, and I think Sarah may have mentioned this, but we will have this next public forum coming up. We haven't set a date yet, but we'll advertise that one. And the board meets on the second and fourth Wednesdays of every month at 5:30 in the DPW building near the transfer station. Those are open meetings, and you're welcome to join us. So, questions from the board? Susan.
So I have a question for Dr. Clapp. You had mentioned that the non-Hodgkin lymphoma near the landfill rate, the SIR was 375, and I wanted to know how you got that figure and what time period. I didn't see that you had put the time period on it.
No, it's from the table in the grading report. It's up on the board in back of you. So it's the time period for the 1 mile radius.
So that was like the third period time, right?
97 to 2000.
92 to 96.
No.
Right?
No.
The height was basically
1997 to 2000.
It's not in the handout. It's up on the board. You can see it.
And then that's a different leukemia thing then? I'm looking at the wrong one. Oh, okay. So this was the last time period that you
Right.
saw that? You had,
I think it bears watching. I mean, I don't think that there's an explanation of why that's there. It's just I'm pointing out that it is there.
and how come that why didn't that show up in your report?
Actually, I didn't focus on that tonight, but there is a section in our report where we talk about the NHL data for those 4 time periods.
And is the non-Hodgkin lymphoma, is that anything that has been found to be linked with landfills? Is there any
It's not so much as linked with landfills, it's linked with chemical exposures.
chemical exposures such as what?
Dry cleaning, for example, solvents that are used in dry cleaning, but also other exposures that, on Cape Cod, for example, breast cancer has been linked to chemical exposures in the drinking water from solvents. Well, that one actually is tough.
So is that, but are there particular, can you envision particular chemicals coming in that high a dose at the landfill to create such a spike in?
Can I envision it? I mean, sure, I can envision it, but I don't have the
solvent?
is a question, and there is at least one solvent that was measured, but I don't have the detailed information about what was exposed, what was in the groundwater, and what's volatilized into the air 10, 15 years ago. So I'd be, speculating.
Thank you.
Just to follow up on that, Dr. Clapp, the confidence interval is 77 to 1,095 on your number there. I'm not entirely sure what that implies. Does that imply that the number could be anywhere in that range given that data?
Yeah, that's the idea. It's not a formally statistically significant elevation when it's got that wide a confidence range, and the lower end of it goes below 100. That's what's the meaning of the confidence interval. So it's it's based on only 3 cases, so that's why it's so uncertain.
Right. What level of the SIR would you anticipate for a real cluster, for a spike that would be like Woburn?
Well, Woburn was childhood leukemia, rare cancer, and just kids. And the first excess that was seen was 12 cases, and 5 were expected.
What does the SIR look like in a place that was a cluster?
I don't think there's some magic number what the SIR has to be. It's what it was in Woburn. It was 12 cases and 5 expected, something like that. No, it's not just really more than twofold.
A little more than double.
Right.
Has there been much national discussion around disease incidents around landfills? You had mentioned Helsinki and Montreal. Sounds like pretty thin data.
Yes.
I kind of would anticipate there'd be a lot more discussion.
There's a lot more about hazardous waste landfills and hazardous waste sites. And there's lots of those studies, but not so much about municipal, waste dumps where people are, kind of everyone has one in their backyard.
Is there this kind of concern happening statewide? Are you hearing from other municipalities with landfills?
Well, we're involved in we do a lot of work down in New Bedford, and there is a city-owned dump that the high school was built on, actually, and the middle school had some fill from that dump. So there are a lot of landfill-related issues around the state, I think it's fair to say. My experience really is limited to this Northampton situation and to New Bedford, but maybe, I don't know, DEP doesn't, regulates or is involved in the oversight of landfills much more closely than the health department is. So I don't feel like I really have a lot to base, my experience is somewhat limited.
There's an organization called the Center for Health, Environment, and Justice, and my colleague Madeline was saying that the science director there compiled a list of studies in the literature around municipal waste landfills. And do you want to say more about that?
Well, I would just say if there's a commonality among them, I looked at it a couple years ago and it was still in process. A lot of the symptoms that are described by residents are not symptoms that would result in a formal diagnosis by a doctor that would then go into a disease registry of any kind. So it's far less specific and far more difficult to study in a formal way, as we have done with the cancer diagnoses.
Thank you.
What was the name of that report? The name of the group?
The name of the group is Center for Health, Environment, and Justice, and they're located in Virginia Falls Church. I think it's this report might be on their website, which would be chej.org. And the person who compiled this landfill list was Stephen Lester, L-E-S-T-E-R.
I guess my final question was, again, circling back to what might a cluster look like. Would it normally be a very specific type of cancer? For example, there's that one in Woburn. Would that be a typical situation where there's something environmental and one particular cancer is caused by that?
If you look in the literature, I think that would be the case. And that's really because I I mentioned earlier how cancer is really, it's a multitude of diseases, and they all have their own risk factors, their suspected causes or known causes. So when an epidemiologist looks at the data, or when an oncologist studies cancer, it really is looking at a particular type of cancer. And I think when we look from an environmental perspective, I think the clusters that have been documented in the U.S. have been a particular type of cancer that's been
specific.
The health department did a study that I wasn't personally involved in, but it was released not too long ago, and it was a study of the Ashland Nyanza Superfund site, where there was documented a cluster of individuals, young people with a rare soft tissue sarcoma. And that was associated with dyes that were manufactured. There was a lot of lagoons and hazardous waste around that Superfund site. And that resulted in an increase in this rare soft tissue sarcoma. So that's another example of a cluster that was identified.
Excuse me, I'd like to also point out that at that site. Okay.
Sorry. Yeah, this is, I'm sorry.
All right.
Thanks.
My question sort of relates to two of the assumptions that, at least to me, seems like it sort of guides the interpretation of the results. And one of them is clearly linked to statistics and why the 95% confidence interval is selected as opposed to another one. And it would seem to me if you picked another number, the range would be smaller, and then all of a sudden data might be significant. So I'd like to hear people speak to that. And the second is this 1 mile radius, and where that, the basis for that, and is there a sense that if that were reduced, might it reveal more exceedances or higher levels, higher incidences than we see with a 1 mile radius?
Well, I guess with respect to the 95% confidence interval, you're right. You could calculate a 90% confidence interval. What I would say is that the 95% confidence interval is pretty much standard practice in epidemiology. The health department many years ago developed a protocol for doing these kinds of evaluations, and we sent it out for external peer review, and the cancer registry uses the 95% confidence interval. So you're right, you can do it differently, but that's what we do typically, and it's not something that's unusual. In terms of the 1 mile radius, we did look, again, we weren't able to do rates, but we did look in a qualitative way at that 1 mile radius. And on a map, we looked within a half mile, we looked within a quarter mile, we looked within a couple streets, So I don't think there's, at this point, much else that I feel we could do that would be informative in that respect.
Thank you.
We need to get back to Boston, so I'm going to beg that if there aren't any more questions from the two of us.
Okay, could I ask one question? All right. And I guess this might be the last one. And this is just to, I'm not a statistician or an epidemiologist, and so I'm trying to understand how epidemiologists think about some of these things. And Dr. Clapp, you mentioned, in returning to this NHL case, four cases, 2 expected, I guess within a 1 mile radius, and an SIR of 375. Does that make you concerned about environmental factors that aren't incorporated in the model that comes up with 2 expected?
Well, I'm not sure those 2 pieces of the question. It makes me concerned, yes. And I think I said that when I was talking about it. I'd like to know whether those people, the 3 women or the 1 man, were long-term residents or short-term residents, and that's a fairly easy thing to find out. I mean, you have to call them, so there is a process. And we in this room are not going to do it. It's something that the state health department people or the cancer registry people themselves, working perhaps through the physicians, could do. But it is doable. It has been done in other circumstances.
If they were long-term residents, would you be
more concerned? I'd be more concerned than if they had moved in recently and they got their diagnosis, within a short period.
So, let's take a hypothetical case, and you've got a large census tract, I guess. And you have a rare cancer, you find one person that has that cancer in the tract. And your model says there should be one person, so an SIR of 1. You break it down into blocks, into 10 blocks. That person only lives in one of the 10 blocks. And so 9 of the 10 blocks have an SIR of 0, and then 1 would have an SIR of 1,000?
Yeah, well.
Would you be concerned about that one block?
If you slice and dice, that's sometimes called the Texas sharpshooter fallacy. You shoot a bullet in the side of the barn and then draw the bullseye around that. To do that, I don't think anyone at this table or any of these tables would be anxious to do that or would do it that way. So
that wouldn't concern you?
No.
Even if there were 10 rare cancers in each single block had its own one cancer, and as a result, you would have SIRs of 1,000 for the 10 different cancers, one for each one of the blocks. Wouldn't bother you.
Well, I think you're just extending the hypothesis to other different types. No, I would go by, first of all, I think actually a 1 mile radius is sort of a simplistic model of who's exposed. If there were a plume or there was some kind of air model, I'd actually draw that boundary and then see what was going on inside that population. Perhaps the way the gradient folks did it by estimating the population and then calculating how many you'd expect within this exposure plume and then what you had. Mm-hmm. But apparently the details that are necessary to do that plume are not available. So they went to the 1 mile radius.
Right. So like a different.
I think what you're saying is, that's sort of exactly the point. If you analyze data a whole bunch of different ways and come up with the same answer, then it's saying the data are robust and that answer is likely to be right. But if you break it up in a bunch of different ways and you only get one answer one way, then you really, it could be that one way is the one right answer, but it's, you really have to look further to see if maybe it's just a function of how you divided it up.
Yeah, all right. Someday I'll understand.
Sorry.
Yeah.
Dr. Cohen, you made a statement that this is just descriptive epidemiology.
Right.
So is there such a thing as inferential epidemiology?
Well, at least in our field, we call it analytic epidemiology, where you actually interview the people, and then you interview maybe controls that don't have the cancer, but then you ask them both the same set of questions and see if there's any difference in what they were exposed to, and then you calculate, for example, something called an odds ratio in an analytic study. None of these people were contacted. This was based on routinely reported data, cancers or asthma or any of the other conditions that were reported. So it's more kind of a first step. I think Julie referred to it as like a screening test or screening exercise. That's what it is.
Okay. Anything else from the board? Oh, yes.
Let's make a move that we adjourn.
Very good. I think that's well received. Is there a second for that one? All in favor? Opposed? We are adjourned. Thanks very much, everyone, for coming.